May I request Dr. Samir Guliani to also come on stage on behalf of Elkim. Definitely, lightning alarm gives a lot of positivity. Thank you, everyone. A very warm welcome once again to all of you. We are delighted to share that this time the ENT is in a phygital format, which means 700 doctors are physically present across locations all over India, and 1,500 doctors are connected virtually. So that's the phygital format which we have taken this time because of the unprecedented times. ENT Conclave, conceptualized and coordinated under the guidance of Sir Dr. Milind V. Kirtane and exclusively supported by Elkim Laboratories, not only for the first time, but from last more than a decade. And this has been possible basically from a strong guidance from Sir. Thank you, Sir. A sincere gratitude on behalf of Elkim family. We have a very delightful session, and I'm delighted to mention that we have distinguished speakers in today's ENT Conclave. We have Dr. Nupur Kapoor Narurkar, Dr. V. Anand, Dr. Srinivas Kishore, Dr. Gaurav Medikari, and Dr. Madan Kapre as a distinguished speaker who will be presenting their surgical case studies, followed by a discussion on every session with from an esteemed panel of moderators. We have Dr. Amitabh Roy Chaudhary. We have Dr. Renuka Bradu. We have Dr. Hetal Marfatia Patel. And we have Dr. Monish Grover with us for moderating the session. So this is going to be the format of a scientific session of 30 minutes followed by 15 minutes of moderation. We also have Dr. Bachi T. Hathiram in the as a moderator in one of the session. So welcome to all the speakers and the moderator from the core of our heart. Thanks for giving your time and giving your expertise to make this 11th ENT Conclave, to start with this 11th ENT Conclave. Thanks a lot for this. Today, ENT Conclave has been chosen on a very special day. Today is 5th September, celebrated as a Teacher's Day, to basically pay gratitude to our teachers, mentors, who have helped us, all of us, to rise in our career, who have guided us. On this note, I would like to mention the quote of Dr. William Arthur, who is a motivational speaker. He says, the average teachers tell, the good teacher explains, the superior teacher demonstrates, but a great teacher inspires. So, sir, wishing you a very, very happy Teachers' Day. You have been an inspiration to all of us. Wishes have been pouring in from last 2-3 days or a week from most of the meritorious students of yours. And yes, there is Dr. Subijan who has flown all the way on this special day to greet you. There are your students, there are doctors like Dr. Nupur, Dr. Renuka, who would like to greet you on this special day. So may I request the meritorious students, the students of Dr. Milindri Kirtane, to come forward and grace the occasion for this. Sir, sir, your gracious presence is required here, sir. Please. In fact, happy Teachers' Day to everybody over here, all the esteemed guests. Once again, a big round of applause for everyone. Okay. So there is yet another surprise, and especially mentioned by Dr. Hetal Marfatia Patel. And there's a small cake which is there, but a lot of full of wishes, full of gratitude, full of warmth. So request once again, sir.
I thank you very much, sir.
Sir, you have been guiding LChem from last more than a decade. So a token of gratitude from on behalf of LChem as well. I'm sure we have been able to figure out some of your liking, and when you unwrap this, you are surely going to like this token of gratitude from us. This we could figure out. Yes, sir. So a small token of gratitude from Alchem for you, sir.
Don't know what to say. Thank you very much. It's a karaoke system. So after the program today, those of you who would want to sing can. Thank you very much. Just what I would love to have had, and I think you've chosen it very wisely. Thank you very much.
Now, I think not taking much of time, I will again invite sir to set the tone of the scientific agenda and express and guide us and navigate us through this scientific proceeding. Over to sir. Thank you, sir.
Thank you, Team Alchem, for all these wonderful things that you've said about me and done for me. There are no greater pleasure for a teacher than to have students who overtake you. And I can see lots of them in the auditorium here. That's the greatest pleasure a teacher can have. First of all, let me welcome you to this 11th edition of the ENT Conclave, brought to us courtesy and unrestricted educational grant from Alchem. We thank you very much. You've done good service to us because you brought us the best of speakers all these years. It's been a fantastic learning experience, and I compliment you because you've always concentrated on the academics. Today's Teachers' Day, so it's a day we remember. Of course, we remember our teachers every day. When you operate, you do something and you remember that, oh, this was taught to me by so-and-so. This is where I saw it. But today is a special day when we offer prayers to them and say thank you for all that you've done for us. We have a lovely program today. Nupur with the moderator Amitav Roy Chaudhary on Kashimas, because bilateral vocal cord pulse is an emergency that all of us face. Dr. V. Anand with Monish Grover as the moderator on intratympanic injection, which is something that almost every ENT surgeon does. He's going to tell us when, how much, how many times, and what indications. Srinivas Kishore is going to talk to us along with Bachi Hathiram as the moderator for obstructive sleep apnea, but we've asked him to concentrate on the most difficult aspect of the surgical thing, the base tongue. That's where everybody has a bit of a flutter when they have to do it. Then we have our rising star, Gaurav Medicari, a fantastic surgeon, with Dr. Renuka Bradu, because the subject is endoscopic management of inverted papilloma. And Dr. Medicari has been doing fellowships abroad, has trained himself. And of course, I cannot think of a better person than Dr. Bradu to moderate a session on endoscopic sinus surgery. And lastly, we have Dr. Madan Kapre, who has a tremendous experience on this rather sticky field of oral submucous fibrosis, the incidence of which we have seen has risen so much because of the Pan and Gutka revolution. And we have none other than Dr. Hetal Marfatia Patel, who is now the head of department of ENT at KEM. And The relevance here, I want you to know, of course, Hetal has been doing a fantastic job as a head of department there, but the disease of oral submucous fibrosis was first described by the late Dr. Joshi when he was head of department of the KEM hospital. So Hetal has now taken over that mantle. So that is the relevance of her being the moderator for the oral submucous fibrosis. Just one word of instruction to the moderators at the various centers. You have this grid view. And at the end of each talk, we have reserved some time for question and answers where you will get questions coming to you typed in the question column or the chat column. As moderators, you weed out the questions which are duplicated or which you feel deserve to be asked. At the same time, in the various centers, there are people with you who can actually write their question on a piece of paper and pass it on to the moderator. So whenever the moderator has questions to us, he will just raise his hand and he will be unmuted and he can ask the questions which have both come to him from people around him on paper or those which have come in on the computer, on the chat box. And lastly, would request all people who are attending, both physical and digital, to give us a feedback, because hopefully next year, the 12th ENT Conclave will be a physical meeting, hopefully. And at that time, we would like to have from you your suggestions as to what you would like, the type of program, the subjects to be covered, whether you want surgery, cadaver dissection, live lectures, whether you want panel discussions, and the topics you feel you would want covered, so that we can arrange the program according to what most of you want. So I wish you a very, very happy learning day today, and wish all the teachers who are there present in this program a very happy Teachers' Day. Thank you.
Thanks a lot, sir. Now I would introduce Dr. Supriya to come forward from LK Medical team and take forward the first topic, talk about the credentials of the speaker and moderator. So over to Dr. Supriya. Thank you.
Thank you, Prince sir, and a very good morning to everyone here, and happy Teachers' Day, because we just celebrated that, and Dr. Kirtane has made a very great start of the 11th conclave today. So it's my privilege to introduce and welcome our moderators as well as speakers today. Just a second, excuse me. The slide shows. Yeah. Just a second. This one. Which one? Okay. Yeah, thanks. So let me introduce our first speaker of the day, Dr. Nupur Kapoor Nerurkar. She is practicing exclusively as laryngologist and is currently heading the Bombay Hospital Voice and Swallowing Center. She is the only Indian to be a fellow of American Bronchoesophageological Association as well as the American Laryngological Association, executive committee member of the International Association of Phonosurgeons, and she is also a chief editor of the textbook of laryngology, which is the official textbook of APSR, and also authored Atlas of Phonomicrosurgery in 2017. She is the associated editor of Laryngology Volume, Otolaryngology and Head and Neck Surgery series, and also a course director for 14 live phonosurgery workshops at Bombay Hospital so far. So I welcome ma'am. Thank you so much. Yeah, ma'am. Should I remove this?
Yeah, just get the power on. Good morning. I'm so delighted to be with all of you here today after 1.5 years of taking lectures from my bedroom. So it's indeed a pleasure. Of course, I'm doubly delighted that it's the 11th ENT Conclave for which I'm taking a talk. Alchem has been doing an amazing job since the last 1 decade. And of course, having Dr. Kirtane at the helm of it, steering the course and making the scientific program very relevant, very on point, with, of course, the icing on the cake being Teachers' Day. So nothing could be more perfect than that. I just want to mention that Dr. Kirtane has had hundreds of students, no doubt, from KEM, but I think he has mentored thousands of people all over India and abroad. And all these mentees, I think, are now settled all over the globe. And I think Dr. Kirtane probably has no idea as to what he means to us in ENT. I cannot imagine ENT without him. On behalf of all his students and mentees, again, I'd like to take this opportunity to thank him. Thank you very much, sir. So, as a student, this is what I feel on Teachers' Day. Dr. Kirtane asked me to talk today, actually make it more of a video presentation on Kashima chordotomy, because it's something which all of us as ENT surgeons can, do the surgery. And this is something we do encounter in our practice, unfortunately, when you have bilateral vocal fold paralysis. So it's very relevant to all ENT surgeons. It's not really a niche surgery, so to speak. So in bilateral vocal fold paralysis, before I talk about Kashima and what we should do, let's just talk about when do we do nothing in bilateral vocal fold paralysis, because that is also important. When you have a situation where the patient has got bilateral vocal fold paralysis, but there is serviceable breathing and there is swallowing without aspiration, consider it as a sleeping tiger. You don't want to wake this tiger up. Leave the patient alone, but definitely follow up the patient, because it may happen that vocal folds, which are slightly abducted over time, get adducted, and the patient then develops stridor. So to show you an example of what I mean by this is a patient, this is the laryngoscopy of a patient who had unfortunately developed mucormycosis of both the lungs. Both the vocal folds had a slight motion and about a 3 millimeter glottic chink. We did a FEES to confirm that there's no aspiration, so we could take the Ryle's tube out. The patient had a serviceable voice. Is the audio?
No.
Yeah, you can hear that now. So we leave this patient alone. But when do we do something in bilateral vocal fold paralysis? When you have a patient who comes to you in this situation, she's got an inspiratory stridor, her laryngoscopy shows a glottic chink of less than 1 millimeter. This is clearly a situation where you need to do something. What is that something that you are going to do? So this is a symptomatic patient, in this situation, stridor, but you could have someone aspirating very badly. If it's acute, an immediate tracheostomy is the best thing to do. There is nothing to shy away from doing a tracheostomy. When it is chronic, let's say the patient's had a dyspnea on exertion, which then culminates into a frank stridor at 5 months or 6 months, then you have various other options. If the patient doesn't already have a tracheostomy, you could consider those options straight away. Those options could be many. And today we're going to talk about Kashima, which is one of those lateralization procedures. And then there is a little bit of conversation and surgical management with selective renovation, which is not part of today's talk, but just that we should be aware, and even laryngeal pacemakers. So we talk of it as Kashima chordotomy, but I think we tend to forget it's a Dennis and Kashima chordotomy. So there are two individuals associated with it. Dr. Dennis from Atlanta, Galveston, he's still practicing. And then we have Dr. Kashima, who had a very, very interesting life and career. The last 3 decades of his life was in Johns Hopkins, where he was with Dr. Dennis. And he was actually an amazing teacher, is what I discovered. And he got the Department Teaching Award. So again, a good surgery to discuss today. We are talking about Kashima chordotomy, but there's something interesting known as a Kashima maneuver, which was something his students coined for him. He was such a particular teacher that anytime he saw a student, he'd want to know every little bit about the patient. So the residents would try to go home without going past the door of Professor Kashima, which was known as the Kashima maneuver. So I thought that was interesting. So I don't know if I ever did that in Sion Hospital with you, ma'am. So this is the publication in 1989 of Dennis and Kashima, where actually they described the CO2 laser posterior cut as a chordectomy, mind you. So it's not chordotomy, and they've written chordectomy. So the difference between the two is chordectomy is you're actually taking out a chunk of the vocal fold. And a chordotomy is when you're just making a cut, which is what we commonly do now, which is a little bit of a modification. So what actually Dennis and Kashima have described was like a cookie bite removal, laterally 4 millimeters and anteroposteriorly 4 millimeters, just anterior to the vocal process. So just removing that entire chunk. And that was the laser posterior chordectomy, which was described. And it was done unilaterally. And about 30% of the patients, they mentioned you need to go in for the other side, which is even true till today. So the principles of Kashima's procedure stand true even till today. And this is typically what a Kashima chordotomy would look post-operatively, where you have this like cookie bite. But what happens in these patients, and this was the observation of many surgeons, is that over time, you've made this big opening, but over time there's scarring. And sometimes 15 to 20% of the patients will come back with so much of a scarification that it's difficult to actually identify which side was a Kashima done. So then you need to go in for surgery again. So in an attempt to prevent that or decrease the chances of that, there have been certain modifications of the Kashima chordectomy. And the two main modifications really are that if you consider this cookie bite, instead of doing a cookie bite, the cookie bite basically is separating the vocal process from the vocal fold. But if you make a transverse cut, just anterior to the vocal process again, but you go all the way laterally to the inner perichondrium of the thyroid cartilage, then you're separating the vocal fold, not only from the vocal process, but from the thyroid cartilage also. So you get a much larger glottic chink. And what happens is because the vocal fold retracts anteriorly, the healing takes place in a situation which is not the original bed of surgery. So chances of recurrence are less. So we are going to be today seeing the video of this modified Kashimas, the chordotomy, which is what most of us typically do. And it's just one case study because sir said, just explain the entire surgery. So the video is going to be about 15 minutes. This is the preoperative stroboscopy. Actually, it's not a stroboscopy, it's a feast of the patient. This was a patient post-thyroidectomy. Tracheostomy had been done for stridor, and he had a very rocky phase actually for almost 6 weeks with aspiration. So, and which settled over time. But before we did the Kashima, we wanted to make sure that there's no aspiration with water and liquids, because just remember when you do any lateralization procedure, technically, there could be a little bit of aspiration. So someone who's had a rocky phase, make sure that you do a functional endoscopic evaluation of swallowing. That's a green sterile water. No issues. So we move ahead with the surgery. This is the preoperative voice of the patient. It's always a good voice because the vocal folds are in an adducted position.
2, 3, 4, 5, 6, 7, 8, 9, 10.
And then he takes a deep breath in, of course. And so we change this speaking tube into a Mallinckrodt laser safe tube, which has 2 cuffs, and we tie it up. And this is how the position is in the OR. So typically we use in our OR in Bombay Hospital, a Muse stand over the chest, which on the side is attached to the table. So the advantage is that when you move the table up or down, the Muse stand will move with it because the chest piece is going to be on the Muse stand. The position which we use is typically a neutral head position, not always the Boyce's position. And what you see over here is a tooth guard. We always try to protect the teeth because that is a little bit of a concern in MLS. And this is what the OT setup is like. Always remember in laser surgery that the anesthetist should not be using nitrous oxide at all. And the combination of gases should be 75% atmospheric air and 25% O2. You want to keep the inflammable gases to a minimum. Of course, you also want to cover the face with moist gauze. You're using a laser microlaryngoscope. And by the side of it, what you see over here, this tubing over here is the laser suction, which is attached for the fumes of the laser surgery. What are the settings of the CO2 laser, which typically I like to use? A scanning system. Scanning means the beam is not at one point, so it's scanning the surface. So the char developed is very minimal. And we work in a repeat mode, super pulse. The length could be 1 millimeter, 2 millimeters, it doesn't matter. And the depth is not in millimeters. One suggests 250 microns, two suggests 500 microns, and so forth. Now, what is this time on and time off? The time on is when you do a continuous laser use, it is it's not zzz. So the time on is, let's say, 0.08 seconds here with a cooling off period of 0.35 seconds. So enough time for heat dissipation to be prevented and charring to be minimum. We come to the surgery now. So if both the vocal folds are not moving, you can choose any one side. Typically, the surgery should be done unilaterally because you want to keep the voice as good as possible. And if that is not sufficient at 4 to 6 weeks, then consider going to the opposite side. So the first thing we do is put a patty in the subglottis. This is a patient who's got the tracheostomy. Therefore, you're not seeing any endotracheal tube. So we put a large saline-soaked patty in the subglottis. And then the first thing you want to do is you want to confirm that there is no cricoarytenoid joint fixation. There's no posterior glottic stenosis. So we use a flap elevator and we are pushing the left vocal fold first and the right vocal fold is not coming along with it. Similarly, we are lateralizing the right vocal fold, left vocal fold is not coming along with it. So no posterior glottic stenosis. Now we're actually palpating the left cricoarytenoid joint and it's nicely mobile. We do the same thing on the right cricoarytenoid joint, again, nicely mobile. So we've got a case of bilateral vocal fold paralysis. Of course, the history also did not suggest anything differently. We've decided to go with the left Kashima, in which case you want to keep the scope a little bit focused more on the left side so that you can see the left ventricle and a little bit of the left false vocal fold also. And we will see why that is important. Now what we're doing is we're palpating with this blunt flap elevator, the vocal process. So if you see carefully, there's a white sort of shadow you will see over here. This white shadow is the vocal process. And on palpation, you get a very clear idea of where it's ending. You get a dip. That is where you're going to make your lateral cut, just anterior to the vocal process. And as I mentioned, in the modified Kashima chordotomy, you're going as laterally as you possibly can up to the inner thyroid perichondrium, which is going to be a place of brisk bleeding. So it's important, even though you're doing laser surgery, that you must have insulated forceps, insulated suction, and a cautery ready with the patient, because really the completion of the surgery is that brisk bleeding, and that cannot be controlled with the laser. So here we've palpated, you see that indentation taking place just anterior to the vocal process. Now we've started our chordotomy cut. From medial, we're going to be going laterally. This is a brilliant surgery to be doing for surgeons who want to later on do chordectomies for malignancy, because you will see the cut going through epithelium, ligament. Now we're reaching the muscle, and you get a very good idea of how the CO2 laser behaves with normal tissue. How do the muscle fibers play a part? So though we are making just a transverse cut, you will see, because of the tensile nature of the vocal fold will start moving anteriorly. And the opening that you start obtaining is triangular and not like a linear cut. So there's no need to be doing a chordectomy, just a chordotomy or cut suffices. Can you see now what we are seeing is that's the epithelium. This is the ligament where my red helibeam is. And this is the muscle layer. So we can identify the layers which we are cutting. And this cut has to be through and through. So you will cut the superior epithelium on the superior surface and the ligament, then the muscle, and then you'll actually see the infraglottic epithelium also. So you want to cut through and through. That is important. As we progress laterally and as the muscle fibers play a part, the opening will keep getting better and wider. So and we'll keep going laterally, but what we need to remember is that 1/4 of the true vocal fold will be hidden underneath the false vocal fold because that's the ventricle. You can't forget about that because you want to get to the inner thyroid perichondrium. So you have two options. One, you can take any flap elevator and retract the false vocal fold laterally and cut the rest of the true vocal fold, or you can cut the false vocal fold in the same line and in the same direction, which is what you're going to be seeing in this particular case. So that is so that you cut the true vocal fold through its entire thickness. That's the only way you're going to reach the thyroid inner perichondrium. Now, when you're cutting the muscle, as you're seeing right now, you start getting a little bit of bleeding, and it's okay if you need to control that bleeding with the insulated suction. So typically on the vocal folds, we never recommend the use of a cautery, but when we are doing work for malignancy and when we are doing work for airway, like a cordotomy, it's okay to be using the cautery when needed. Some of you may wonder whether this surgery is only restricted to surgeons who have a laser in their setup, but that is not so because this is for airway. So this surgery can effectively be performed even with a coblation. It can even be performed with a diode laser. Can it be performed with a cautery? It can, but then the chances of a granuloma formation become much higher. The healing wouldn't be that good because the heat dissipation with a cautery is much more. So there are many modalities you can use other than laser, coablation definitely being one of them. Now what we're going to do, this red line which you see all along, by the way, is called the AccuBlade. And now the AccuBlade is seen here on the false vocal fold because we are going to be cutting the false vocal fold so that we can see the 1/4 of the true vocal fold which is lying underneath it. That is the ventricular bit of it. Basically, the CO2 laser is invisible. So the red line which we are seeing is a helium neon light which is attached to the CO2 laser known as the Henny beam so that we can see what we are cutting. And if you don't have a scanning system, then you would get a spot and not a line. It's only when you have a scanning system that you're able to be using what we call an AccuBlade. Now, we do use a lot of cotton pledgets and cotton balls during surgery in the larynx. Here you can now identify the part of the true vocal fold which was not seen earlier. And this would be your final completion. And this will also be the point where you will get sometimes very brisk bleeding. Actually, it can be a little bothersome. So you can try to stop just short of the inner thyroid perichondrium, but typically you do get the bleeding from the superior laryngeal artery. And occasionally, if you go very deep, with the laryngoscope, you don't stay at the false vocal fold level, you may start cutting into the subglottis. And that's not what you want to do. You just want to make the cut in the entire thickness of the true vocal fold without going and starting to cut the epithelium of the subglottis. That means you don't want to go below the infraglottis. Always keep pushing the subglottic patty to the side which you're operating. And I keep doing that. The reason being that though we are using a laser safe tube, any laser safe tube will always have the cuff which is not laser safe. So you don't want to be laserizing the cuff. Of course, the advantage with the Mallinckrodt tube is that there are two cuffs. And you can have the proximal cuff with the little methylene blue so that if you do puncture it, the field becomes blue and you know about it. Why are we so concerned about not puncturing the cuff? Because a laser is inflammable medium. So if you have only one cuff and you puncture it, then even that 25% oxygen comes into circulation and you can potentially have a laser fire, which we want to avoid at all costs. Of course, we never want to have a laser fire, but if there is a fire and if there is an endotracheal tube, you'll yank it out, disconnect the circuit with the oxygen and give cold washes. Now, this is the completion, what we are reaching, the completion of the surgery, which is when we'll expect the bleeding to start from the superior laryngeal, because even on palpation, you'll be able to palpate a firm thyroid cartilage, which is the inner surface of the thyroid cartilage. Don't keep the small cotton patties or pledgets ever within, because it's very easy for them to get lost. So if you're using them for dissection, that's perfectly fine. Make sure that you clean the char and bring them out. The only patty which we keep in is the very large subglottic patty, which is without a thread. So that's the bleeding I've been talking about. We do sometimes keep patties for hemostasis, but then we keep a thread attached to them and a very strict patty count. So this is, always to be expected as a kind of completion of the surgery. We use usually 15 watt insulated suction. Sometimes you need to actually catch the blood vessel. You can use a clip, but typically I've not used a clip in this situation, laryngeal clip for the control of bleeding. And at the completion of surgery, it's a good idea to give what I call a laryngeal wash, so that not only the char, but because we use patties and cotton balls, sometimes little threads get left behind and you don't want them to become, a healing issue and granuloma formation. So just give a nice laryngeal wash with a thick suction inside so that everything can be cleaned off. Or this is now what I'm showing you is actually the muscle fibers of not only the vocalis, but the thyroarytenoid muscle also. Sometimes they start prolapsing within the laryngeal sort of introitus. So just to make it smooth and even cut, I'm laserizing the cut edge of the thyroarytenoid muscle so that it shrinks in. So one important point over here is when you are performing this kind of laserization, don't cause any decrease in the length of the medial vibrating edge of the vocal fold. So you see the medial vibrating vocal fold now, the new position is as such. So we don't want to decrease this length over here at all at the medial edge, because that is responsible for your good voice. But you can definitely be, sort of increasing the airway lateral to it. That's just going to help in a good healing process and not interfere with the voice quality of the patient. So that's what this modification actually is. One, that you're separating it from the thyroid cartilage, the vocal fold, not just the vocal process. And second, that the vocal fold now, the healing vocal fold, the new edge, is at a different position than the area of the surgery. And therefore, the chances of scarification are less. They're not zero, but they are less. Now, after this is a modified Kashima chordotomy, which you saw, but occasionally, depending on the lie of the vocal process, I kind of take a call as to whether I want to excise it or not. Because occasionally, only after this modified Kashima, when the patient comes back post-operatively, I see a good opening, and then I see the vocal process kind of protruding into the larynx, and then another small opening behind it. And that is, I feel, a disservice to the airway. So as you see now, I am excising the most anterior and medial part of the vocal process with its overlying epithelium, so that at the end of the surgery, I don't have a big opening with a little vocal process and a smaller opening behind it. And it's just one big triangular opening on the left side. So I'm just excising the anterior part of the vocal process with the overlying epithelium. And of course, whenever we're doing the surgery, there are chances of a granuloma, carbon granuloma formation, which you do want to avoid. So it's important to have a post-operative follow-up. That's also a reason why in these surgeries, I prefer to give at least 1 to 2 days of IV steroids and follow it up with 4 to 7 days of oral steroids. And if I feel the healing is not good, I even start steroid nebulization for the patients. So when I give steroid nebulization to any of my patients, I always tell them to take 5 minutes of steroid nebs, and after 20 minutes, follow it up with sterile water nebs, so that fungal laryngitis does not become an issue after 20 minutes, so that there has been some absorption locally of the steroid nebs. So that's something you can think of. And because any kind of reflux would take place in the posterior part of the larynx, and acid on healing tissue is a very bad idea. It's a good idea to give, even patients who don't have LPR, it's a good idea to give proton pump inhibitors for 4 to 6 weeks till the healing is complete. So that is what we do for most of our patients. Occasionally we give alginate also. Antibiotics, so we give intraoperatively to all our patients, and follow it up with oral antibiotics for 5 days. In usual MLS surgeries for polyps and cysts, we're not giving any antibiotics post-operatively, only the one antibiotic intraoperatively. But when we are cutting the cartilage or getting near the cartilage, I prefer to give 5 days of antibiotics. So this is going to be sort of the completion of our modified Kashima chordotomy, where we have also actually removed the anterior part of the vocal process using a scanning system of the CO2 laser. All our patients do receive preoperative and postoperative photos with a 0-degree telescope. I find medico-legally also, it's a very valuable thing to do, to give them a pre-op photo and a post-op photo to show the proof of surgery having been done. Let's say you have keratosis and everything comes back. You want to make sure and document that you had removed the keratosis. I personally do not think it's a good idea to give video recordings of the entire surgery because I think that complicates issues and creates too many queries. So this now we would finish it with the laryngeal wash. And if this patient did not have a tracheostomy, it would be very important also to give a 4% or a 10% lignocaine spray. You can even apply 10% lignocaine on a patty and put it on the medial wall of the pyriform fossa for about 2 to 3 minutes. The reason is you don't want a laryngospasm, definitely not on a patient like this who has got a restricted opening or a glottic chink, which is inadequate. This is the laryngeal wash, which is taking place. Make sure that you take out all the patties at the completion of the surgery. This is the 0-degree telescopic view of the spinal surgery. 10 millimeter telescope is used. So this is the patient's voice immediately on extubation.
2, 3, 4, 5, 6, 7.
And to just show you the voices of a patient without a tracheostomy. So this is another patient, preoperatively, post-thyroid, in stridor. And then immediately after surgery, very soft voice, but by 6 weeks it becomes a serviceable voice.
हाँ अभी सांस कैसी लग रही है? अभी अच्छी लग रही है और पहले काफी तकलीफ थी? हाँ अच्छा है अभी रात को भी ठीक है? हाँ ठीक है मैम.
So this was the post-operative care, which I've already discussed with you while I was showing you the surgery. When there is a trachea, we don't immediately take out the tracheostomy on the same day or next day. We do a downsizing and we do it over 4 weeks because we are not in a hurry. We want to see that the healing is good. And the Kashima bit is over, but just 1 or 2 slides to tell you that in the world now, selective laryngeal renovation is being performed in a few centers. To give the patient an opportunity to have a good voice and a good airway, where in selective laryngeal renovation, you're trying to attempt to get motion of the vocal fold. So this was a patient, a pediatric patient in whom we did it, a 6-year-old child of papillary CA. So you take the greater auricular nerves from both the sides, and then you find the C3 branch of the phrenic and take one of the greater auricular nerves, attach it, and use the forking of the greater auricular nerve to insert into the PCA muscles, both the right and the left. This insertion into a muscle is known as neurotization. And you also do a little bit of adduction on both sides by again taking the other great auricular nerve and suturing it between the ansa and the recurrent laryngeal nerve. And the person who's done the maximum cases is Professor Jean-Paul Marie in Rouen, who I had the opportunity to train under. And laryngeal pacing is something which has not come into practice commercially, but Professor Muller has been doing a lot of work on this. So I hope in the next couple of years, it's something which we may be able to offer our patients, where you actually have a electrical implantable stimulation again of the PCA muscles. So I'd like to thank you very much, and also just want to welcome you all to the 15th workshop on phonosurgery, which is going to be an operative webinar on the 13th and 14th of November. And thank you once again, Alkemin and Sir. I'm happy to take questions. Sure.
Yeah. Thank you so much, ma'am, for the insightful demonstration. Now I'll call upon Mr. Prince from Alchem. Sir, please felicitate ma'am for her talk.
We wanted a fresh flowers right from the orchard, so it took some time.
Thank you. Thank you so much. Thank you. Should I be here for the questions?
Questions from there? We can have them. Yeah, that's also there.
So sit there.
Ma'am,
Should I take?
Yeah.
Thank you.
We'll just introduce our moderator for the session on Kashima chordotomy. We have Dr. Amitabh Roy Chaudhary for the moderator. Thank you. So Dr. Amitabh Roy Chaudhary is the ENT and head neck surgeon from Kolkata, and he's the professor and HOD Department of ENT at Vivekananda Institute of Medical Science and visiting laryngologist in Amri Hospital, Kolkata. I welcome sir to conduct the to moderate the session. Yes, sir.
Good morning. Thank you, Team Alchem, for involving me, and also happy Teachers Day to Professor Kirtane and also for involving us in this program for last 10 years or more. I think Dr. Nerurkar has given us such a mind-blowing presentation on one of the most challenging situation in otolaryngology practice, which many years ago we didn't even know what to do because there were many procedures starting from suture lateralization to arytenoidectomy, which were not until this Kashima or Dennis and Kashima operation has come to our basket. There is one, so at one moment I was forgetting whether I'm attending an anatomy class or a laryngology class because it was such a beautiful anatomical plane wise dissection. So wonderful. Congratulations, Dr. Nupur. As always, you have mesmerized the audience and us. Before we take other questions, just there was a comment from Dr. Anand, which I have seen in the chat box. He said, injection of Dexona locally into the operated area when you have done this kind of a widening procedure. Probably he does that, but what is your experience or your take on that?
Thank you so much, Dr. Amitabh, for all your comments. What Dr. Anand mentions is something which some surgeons, laryngologists do like to practice. And I think there is no harm. In fact, it may help with the healing. The important thing to remember is that if one is wanting to inject steroids, you do it prior to the surgery. You do the injection exactly in the area of the cut, about 2 to 3 minutes prior to the surgery, and then you make the cut. Absolutely.
Perfect. So I think steroid is known to reduce the inflammation, as you have said, and you do prefer to give some oral steroid, but yeah, injection. Even people have injected repeatedly in all multiple airway procedures. So we'll now go to the questions from all the centers. I'm not sure which center has a question at the moment.
Please raise your hand so I can allow to talk.
Yeah, if you can mention who's.
Yeah, Guwahati, sir. Yeah, Guwahati from Guwahati, sir.
Yeah. Amarnath Prasad has asked, what are the complications of Kashima's chordotomy?
Okay.
Contraindication.
Okay. Complications, you mean?
Contraindication.
Contraindication. Okay, Dr. Nupur, I think she has mentioned about the details about the indication, but contraindication. Will you take that?
Yes, of course. Thank you. Well, I'm not going to talk about the fitness contraindications. That's obvious for any surgeries. But there are two situations where one would want to be careful. One would be a post-radiated patient. What happens following radiation therapy is there's a lot of fibrosis of the vocal fold. The principle of this modified Kashima chordotomy is basically the tensile nature of the normal kind of vocal fold, which retracts beautifully anteriorly when you make the cut. Post radiation, that does not happen very often. So what one tends to do then is one tends to start doing a chordectomy, which was the original Kashima chordectomy, which you can do. But then what happens in a post radiated patient is that you have much higher chances of aspiration and swallowing issues. So radiation therapy of the neck area is a relative contraindication, not to say that I haven't operated on radiated patients. The second is, like I mentioned, when a patient has actually posterior glottic stenosis or cricoarytenoid joint fixation. Now, in posterior glottic stenosis, it wouldn't help the patient. If there's a cricoarytenoid joint fixation, there may be still some improvement of the airway. So these are sort of relative contraindications for the surgery.
Thank you. Thank you. So that brings...
Subglottic stenosis obviously should be ruled out. It should not be that you're performing this surgery and missing out on a subglottic stenosis associated with bilateral immobile.
So before we go to the next question, I had a little doubt. Would you tell us about your swallowing management of these patients? A tracheostomized patient and a non-tracheostomized patient whom you have done a Kashima, immediate post-op swallowing management.
And aspiration preoperatively, they have to receive swallowing therapy preoperatively and be swallowing everything normal prior to the Kashima. After Kashima procedure, really, the patients may have an aspiration with water for a couple of days. Other than that, with semi-solids and solids, there's never an issue when you're doing a Kashima. And even that aspiration with water settles almost in 2 days. But what does my swallowing therapist do for patients who do have a swallowing issue is we teach them the supraglottic swallow, or the special swallowing technique where you ask them to take a deep breath, hold their breath, swallow again, and then release their breath, so that you have as much of a supraglottic closure during the laryngeal elevation and during the cricopharyngeal opening phase. And the patients do really well with the Kashima.
Yeah, so what I gather is, I think earlier you give them transit to normal food, semi-solid food, and then normal food is better because it'll not have aspiration. The question from Guwahati was there, I think.
Yeah, Guwahati, sir, you can talk. From Guwahati.
Hello, am I audible? Hello, am I audible?
Yes, sir. Yes, sir.
Yes, Gautam. Yeah.
Yes.
Question is there from Chennai. So Chennai questions will be modified by Dr. Anthony Iridirajan.
There's a query from Dr. Kudus Ahmed.
Yes.
What is,
sir, once again,
we have to
Dr. Nupur's experience regarding bilateral?
Yeah. That's
Can I go
your
on?
experience with bilateral Nupur. Bilateral simultaneous chordotomy.
Yeah.
Is that what I understand?
Thank you, Gautam. So I always counsel my patients that we will always prefer to do a unilateral Kashima because we are trying to give the best possible voice to the patient. And I also explain to them that there is a 20 to 25% chance that the contralateral Kashima procedure will need to be performed, and that decision is done at 4 to 6 weeks. That is when the healing is more or less complete on the unilateral side. So I don't really go into a bilateral in any patient, and that's what I counsel them. I also counsel them regarding the voice as to, and I try to go on a little bit of an exaggeration. So I say, your voice will be like this after surgery kind of thing, so that they're mentally prepared for it. And typically, within almost 10 days to 2 weeks, the voice is absolutely serviceable. Obviously, it's never going to be a good voice for a professional voice user, but it's a serviceable voice.
So if I may add another query to that, what percentage of your patients you have to do a second procedure on the other side later on?
15 to 20%.
That's fine. Thank you. The question from Chennai now, please. Dr. Anthony?
Hello, there's one more query. Dr. Biswajit wants to know the FiO2 preferred.
For
Hello?
laser surgery, right, Gautam?
Yes, yes. In laser
Yes,
surgery, what is the preferred?
So as I mentioned, we use a combination of 25% of oxygen, 75% of atmospheric air, no nitrous oxide, no inflammable agents anywhere in the OR, which means no spirit, etc., ether, nothing of the sort in the OR. Does that answer the question?
Yeah. Now Chennai, please ask your question.
Your views on the laryngeal transplant. How far it's coming? Like laryngeal pacing,
yes.
laryngeal transplant is on the.
Yeah, so laryngeal pacemaking is, of course, a totally different thing. Laryngeal transplant, the very fact that the first laryngeal transplant was done almost 25, 30 years ago, and then that lady had the tracheostomy for the longest time post-operatively, and then we had the same group do another laryngeal transplant after a very long time. It obviously gives us an idea that it is, for various reasons, not the simplest option or not a very easily reproducible option for the rest of the world. Of course, there are so many factors which come into this, because you will do a laryngeal transplant, let's say when there's very bad laryngeal trauma and stenosis, etc. The problem is, of course, that the patient is going to be on lifelong immunosuppressants, is probably not going to have a larynx where the vocal folds are going to be moving. So therefore, there is going to be a tracheostomy for a long time, to maintain the voice of the patient. So I personally feel that probably laryngeal transplant is not something I personally feel is something I am going to be myself looking to train into or doing. But what I'd like to train in fact, what I'm more excited about are things like laryngeal pacing, selective laryngeal renovation, robotic surgeries with the arms getting smaller and thinner and getting more to the glottis rather than just the supraglottis. So that's my personal take on the laryngeal transplant.
Thank you, Nupur. I think one last question from Bangalore, because we have to go on to the next session. There are so many questions, Nupur. Is it okay if they write to you and you
Absolutely. On my email, nupurkapoor@yahoo.com.
nupurkapoor@yahoo.com. I'm sorry to come in because we have to go to the next session. And if you have really queries on this, I'm sure Nupur will be happy to answer. So Bangalore, one last question. You've been raising your hand for a long time. Indore, I can see very senior people there, but I'm sorry that we have to move on to the next session. So you can always contact Nupur. Dr. Dubey, Dr. Sanjay Agarwal, you know where to get hold of Nupur, right? Bangalore, your question.
Yes. Good morning, madam. Thank you for the wonderful presentation. One question is about the role of co-ablator in these cases. Instead of laser.
We have time only for one question now, Nupur. Go ahead.
So coablation, as I mentioned, can very definitely be used, not only for this, even for papillomas. Only challenge being currently there are two wands. One is the thin, one is the thick. Even the thin one is not as precise as the CO2 laser, but definitely the surgery can be done using the coablation. In fact, one added advantage of the coablation system is you've got the cautery already there. So that's an advantage. Thank you so much.
Thank you.
Thank you.
Hello, Dr. Nupur.
Hello. Yeah.
This is Professor Arunabu Sengupta from Kolkata. There is a question by Somnath Shah with an HOD of National Medical College.
Yeah. So thank you
A
so much,
patient with
ma'am and Dr.
bilateral-
Amitabh, for such a wonderful first session. And now we'll move on to our next session on role of intratympanic treatment in sudden deafness and tinnitus and Meniere's disease. And I would like to introduce and welcome our second speaker of the day, Dr. V. Anand. Sir is director of MCV Memorial ENT Hospital, Pollachi, Coimbatore, and director for DNB program also. And sir has contributed in the form of design and serial productions of nasal septum clips for nose type 1 as well as 2 and 3, and design for production of endoscopic video camera as well as still camera attachments in endoscopic sinus surgery. Sir is also the project director for the design and prototype development of rescue of children trapped in bore wells under MCV ENT Trust, and sir has more than 30 publications in national and international journal. I welcome sir. And I would like to introduce our moderator also for the session, Dr. Monish Grover. Sir has played pioneering role in starting the cochlear implant program at this institute of SMS Medical College. And sir has done over 200 procedures and working in close association with New York Eye and Ear Infirmary regarding various radiological studies for cochlear implant. And sir has more than 40 publications in journals of repute and has delivered many talks and won awards in national and international conferences. I welcome sir, and I'll hand over the session to Dr. Anand for his talk.
Good morning, everybody. Can you hear me?
Good morning, sir.
Yeah. So
Yes, sir.
I wish to thank Professor Milind Kirtane, who had been instrumental to bring all of us, and also to organize the meeting in such a way that you enable a lot of participation all around the country, because he's a very good teacher, and on this Teachers' Day, I wish to remark that he was one of my teachers too. So I also wish to thank Dr. Manish, who is here. I know him well, such a nice person, and I'm happy to have him as my moderator. I'll go for my session.
Yes, sir.
Are you able to see my screen?
No, sir. Kindly share your screen, sir.
Yeah. One second. This one.
You have to have the PowerPoint open on your desktop and then go to share screen and then click on the PowerPoint. Yeah, that's right.
Thank you, sir.
Is it okay?
Yes, sir. Yes, sir.
My voice is there?
Yes, sir. Yes, sir.
Okay. Thank you, Professor Kirtane and Manish, for giving me the opportunity to welcome company. Thank you very much. So here we are going to talk about three common problems: Meniere's disease, sudden SN loss, and tinnitus of recent origin. I'm not going to talk about tinnitus of long-term origin. And I have 20 minutes to present this. 30 minutes, isn't it? Right. So this is the history of intratympanic treatment. It's nothing new. Been there for a long time. They had used antibiotic, local anesthetics, and steroids have been used in sensory neural hearing loss. And gentamicin is probably one of the oldest. I still remember one American prof had come here. I think Dr. Sheehy, I think, had used streptomycin in the lateral semicanal in one of the workshops in Madras in the early 90s. That time, the patient was one of civilians from Madras, and I made sure that I got his phone number and I followed him up for 5 years and found that he had a good result. Streptomycin on the lateral semicanal. Now, nobody does it because, it has a lot of toxicity. So now we are shifting to gentamicin. Just this anecdote is to point out that there are many roads to Rome, and the point is to get there. So there are many other drugs, and I will try to cover as much as possible. It will be more of a, it's a technique as well as the medicines what we use also I have to highlight. So basically, we are not injecting medicine into the tympanic membrane because the eustachian tube tends to take it down. There is also a way of putting a grommet and pushing medicine in. That also doesn't work. I'll explain to you why these things don't work. So we have, after about 15 years of working on this topic, We have narrowed down onto tympanomeatal flaps so that we see the round window, clean it, and then apply gentamicin or whatever medicine you want directly on it. So basically, we use a gel foam on the round window and then put the medicine inside. Why I don't like injection and grommet technique? Because the eustachian tube works to our disadvantage. So the indications for intratympanic treatment are these three as we stand now: Meniere's, sudden SN loss, and tinnitus. Meniere's disease, it's a multifactorial disease, you know it very clear well. It has a classical history of the 4 classical symptoms. We used to be taught in the early 90s that there are 3 classical symptoms. Now we know there are 4. There is ear block, tinnitus, fluctuant hearing loss, and vertigo for longer time, not fleeting vertigo. There can be drop attacks in Meniere's, and for drop attacks, my experience is intratympanic treatment works better in drop attacks than giving all the medicines. When you do audiometry, you look for low frequency dip in audiometry, and when tympanometry, please look for brisk stapedial reflex with a threshold of less than 50. So this is a test that has long been given up due to several reasons. One, people tend to forget the old science, and also the side effects of the old science catch up with you. And you know, some patients get bad headaches during this dehydration test. Yes, I agree. But it's our job to modify the test so that the patient's morbidity is kept low and our results are more substantial. So what we do is we use a glycerol of 50 to 70 ml. And in diabetic patient, which is almost 1/5 of our patient group is diabetics in South India now. So there we give furosemide according to body weight. Sometimes it's even 80 milligram. We have to, before this dehydration test is to confirm Meniere's disease. The patient has to be NPO, best is to do it in the morning. And after giving these medicines, you do the audio 3 hours later. Most important is the audio has to be pure tone as well as speech scores. There are cases where pure tone audiometry is almost same, but speech scores improve like anything. And in human life, the people are not depending on pure tones for life. They depend on speech. And intratympanic treatment also we find, even in cases where pure tones haven't changed, the speech scores and the speech recognition changes. So our patients are grateful for that. So for air conduction audio, the classical dehydration test, it should be better by 10 to 15 decibel in 3 frequencies. That's a classical teaching. And that is called a positive glycerol test. Here I put a positive symbol. So in dehydration test, you can have positive, you can have negative, that is same level of hearing. Then there is one more thing which we have uncovered. There is a reverse glycerol, where the hearing goes down when you give dehydration. That's very, very important information. These patients should not be given dehydrating drugs. You give it, yeah, they are going to suffer more. So again, I want to highlight, dehydration test can be glycerol or furosemide. Glycerol in normal people, furosemide in diabetics. It can be positive, where 10 to 15 decibel better AC conduction, better ski score. Negative when it is all plateau. Reverse when the actual hearing and all goes down after glycerol test. So this is one positive dehydration test where you can see the classical, the going up of the air conduction audio. These are, one is a negative test, another one is a reverse glycerol. I'm sorry, I didn't get the correct graph for the real negative glycerol. Reverse glycerol, it can even be down by 10 decibel. And the speech scores matter a lot. So choice of treatment in Meniere's disease. Here I'm going to talk about intratympanic treatment, but not all cases of Meniere's we give intratympanic treatment. You select the history, see if there is a drop attack. Drop attacks, we favor intratympanic treatment, but it is maybe 1 in 20 cases have a drop attack. 19 out of 20 will have only regular Meniere's like our regular cases. So in such cases, when after doing the glycerol test, if it is a positive glycerol test, I prefer to give diuretics, anti-epileptic drugs. Now, diuretics can be, you can use a mix of potassium sparing and regular diuretics so that your ionic balance electrolytes will not change. I believe in giving a brand called lacilactone, which contains spironolactone and furosemide. And anti-epileptic, the Western literature favors, what's that one? Anti-epileptic? Topiramide, or the older literature favors phenytoin, but it has a lot of side effects. So basically, these two drugs are combined for positive glycerol test, and antivirals are indicated in negative glycerol and in first-line failures when glycerol positives are failed for this. The drug that we use is acyclovir. This is the dose, and this has been reported in American Journal of Otolaryngology in 2015 by a guy called Gasek. Now, intratympanic treatment, when we select based on this, we select only when this has failed, then they go for ITT, regular cases. But drop attacks, they go straight for this. 40 milligram per ml gentamicin, the older literature, especially from the Western literature, they talk about buffered solution, this solution. We did all that and we found that is all not very important. You can use the gentamicin that the companies make for intravenous use. It is as good as your buffered and other things. There is no problem. Sometimes patients may get pain or vomiting because of this irritation in the round window, but you have to keep them in the hospital for at least 2-3 hours after this kind of treatment. Intratympanic treatment failures, like we do intratympanic treatment once, after 6 months, if there is a problem, we do it. How do we know it's a failure? We do a caloric test. If caloric test is positive, that means your ITT has not worked well. At least it should be lesser in duration. The nystagmus should be lesser in duration on the ITT year compared to the normal year. So when ITT failure has happened, then you go for destructive procedures. You have many of them, which you are all trained in doing destructive procedures. So this is the dose of gentamicin I use. Standard, straight from the bottle, no mixing or buffering or anything, straight is enough. Sometimes we mix them with Dexona. That is, when we feel Dexona is required for that patient, when there is a sudden dip in sudden attacks, more in attack, then we may mix Dexona, but normally it's gentamicin. That is intratympanic treatment for manias. So this is the actual surgery. The advantage in this particular surgery, this is just a tympanomeatal flap, which most of our junior residents do in our hospital. And this is one such case like that, where they are just opening the tympanomeatal flap, exposing the round window, cleaning it with gel foam and so forth. Finally, we place a gel foam and inflate it with gentamicin. There is a big difference between the ITT done for manias when compared to ITT done for sudden SN and tinnitus, because in manias, you can use a little large gel foam soaked in genta. If it touches drum, nothing happens. But in sudden SN loss and tinnitus, don't allow the gel foam to touch the drum. Drum is super sensitive to Dexona or Solumedrol, and it really melts away if you put too much gel foam and make it touch the drum. So that's a difference. Here I'm showing why all this trouble. Why don't we inject repeatedly, put a grommet? Now, this is a video to show how the round window is exposed and cleaned before putting this medicine. Because once we do tympanomeatal flap, we have injected sensorcaine. So all that sensorcaine has to be sucked out using some gel foam. So this is also the instrument is used to clean out all the adhesions. Unless the adhesions here are all released, the medicine will not go in. This is one of the reasons why we don't like to do injection treatment. Many of these round windows are hidden. They wear a parda, and the parda has to be taken out. You want to put medicine in. It's as simple as that. You can't expect a parda clad round window to accept your gentamicin. That is why we may have to open it. So this is another same. Basically, we have to open out the. Now, this is an article by UC. It's very easy to remember his name, UC. And he even uses drilling of the round window for exposing the absorption of the medicine. So these are not hypothetical or single doctor indicated procedures. These have been accepted by many people. So intratympanic treatment by putting medicine on the round window is accepted. It's a better way of delivery of drug than injecting or putting a grommet. This is just to prove the point. I'm not telling every case you have to drill. So it has reduced the ITT in our practice. Initially, we were doing a lot of sac decompression and sometimes shunting. But last 10 years, we stopped doing all these procedures. And one more thing, ITT can be done by junior residents and elevating a tympanomeatal flap, nicely exposing round window and putting some medicines with precision there. It is a stepping stone to their stepidotomy. And unfortunately, we seniors, we don't teach our juniors stepidotomy. ITT is an ideal way by which they can learn that. So this is my article on this Meniere's disease management for better results, where most of this is discussed in depth. I'll give this reference to Alchem, and I'm sure you can share it later. So now we come to sudden SN loss. You must rule out any history of trauma. And if there is no history of trauma, you can think of intratympanic treatment. Even otherwise, in a sudden SN loss, look for round window rupture, any leak. If you can, just touch the malleus and see if there is some endolymph getting pumped out from the round window when you do this. So when you do sudden SN loss intratympanic treatment with the tympanomeatal flap technique, the first 3 days is ideal, possible in 3 to 10 days. But after 10 days, it's debatable whether it is really helping. There are some doctor patients who wanted it after a month, and due to their persistence, I did. But whether it really helped them or it is naturally came up, I don't know. So one more thing which is very useful, which I found in practical sense is hyperbaric oxygen treatment. It really helps when you combine it with ITT. And hyperbaric oxygen in government centers available in Bombay, Visakhapatnam, Cochin, and there are quite a few private centers now having come up. You require 2.4 atmosphere for 1.5 hours, 10 to 20 sittings. So when you combine your steroid breath with hyperbaric oxygen, your patients have a better chance of recovery. Now we come to the tinnitus. I'm again replying. This is sudden, not 1-year-old tinnitus. Only when other causes are ruled out, like you should rule out tumors, blomas, etc. Then make sure it is idiopathic and it is sudden. Then in the first 2 to 7 days of tinnitus onset, you can try intratympanic treatment with steroids. It's the same medication, Dexona. Rarely I have used Solumedrol, but I find Dexona, my patients with Dexona probably did better. I thought methylprednisolone has a better penetration, but I didn't see practical benefit. I'm talking about literally almost 100 patients. So one more drug which I found is very not at all useful is Caraverine, which is recently promoted, not recently, it's been there. I don't know whether it is approved by all the drug regulatory agencies. Caraverine, I found no improvement when I apply injectable Caraverine on the round window in sudden tinnitus. So this is a slide which I should have put in the beginning. Why we do this intratympanic treatment through the tympanomeatal flap. There is no escape into eustachian tube. It is one sitting and day care procedure. And the medicine that is soaked in the gel form, we know that laryngoplasty, we put gel form soaked in the medicine or whatever inside the middle ear, it stays for 10 days. So why don't you put it on the round window? It will stay for 10 days. and direct visualization of round window to remove that all that mucosal adhesions, because then only the medicine will go in. And there are no systemic side effects like in diabetes, targeted Dexonar to the inner ear, there is no increase in blood sugars. These are the theories behind it. We are almost nearing the end of the talk. I'll try to go fast. So these are the theories behind it. Basically the 3 layers of round window, just like tympanic membrane. But the outer epithelial layer is not stratified squamous, so it has a better absorption of medicine. And it is a membrane, the round window membrane. It can be tweaked in the sense by putting some medicines, we can make it absorb more. So there are many medicines which make it absorb. That's one of the reasons why after some bacterial ear infections, people tend to lose inner ear when round window is made more permeable and the toxins go in. And whereas in some patients, it doesn't happen. So the supporting evidence is they have found that if you topically apply steroids, better thresholds are preserved in implants. And there are other strategies that have been published already. Now, for the younger generation in this audience, there are many unanswered questions as far as whatever I talked about is concerned. Whether Meniere's is caused by hydrops, we really don't know. Not all cases have documented hydrops. I told you, you have negative reverse glycerol. If it is hydrops, why it comes with negative hydrops, I don't understand. Same way, this is very important. The cochlea and the vestibular system can be tuned up or tuned down. For example, if you have a sound system like, I'm sure Professor Kirtane, now he has got a karaoke, he can tune the sound so that he can hear all treble, bass, everything in a high, this one. Or he can switch on the filter, which brings down all the high and low frequencies. Same way, the human sensory organ can be tuned up or can be tuned down. So how we prove that our ear can be tuned up or down? Simple. You do Weber test. We know Weber test is done for conductive hearing loss. It lateralizes to the poorer ear. But try doing it when the patient has Meniere exaggeration or migraine. The Weber will go to the affected side. That is, your audiometry is showing low, but Weber will go to that side. Same way, stapedial reflex thresholds in these patients will be reduced, lesser than 50. You do electrogustometry, we do. That's why I'm talking about this. You find taste variations in migraine and Meniere's. Now, in lower mammals, they found that there is a separate labyrinthine branch that comes from the central nervous system to the vestibular system. In higher mammals, no. I've tried my best to look for these nerves when doing cochlear implant, because you're going through the sinus tympani to make those openings. I've been looking, but I've not found any particular nerve other than chorda tympani. So I don't know, maybe Professor Kirtane can tell, other than chorda tympani, did he find any other nerve branches coming from medial to lateral? Because the original hypothesis was labyrinthine branch transmits from the inner ear through the chorda tympani. From chorda tympani, it again tracks back through the sinus tympani into the vestibule. This was proposed by somebody who said he saw this in a temporal bone dissection, but I have not been able to document it. So that is for neural in lower mammals. We are higher mammals, we don't know. And the higher we go, the more unanswered we become. Whether it is biochemical, your upregulation of cochlea, vestibule. For example, if you have yoga and all, your tinnitus and other things come down. So whether our biochemical system brings down the receptivity and the thresholds of the inner ear, we have to study. And definitely there is a role of hyperbaric oxygen in sudden SN loss and tinnitus. These are simple things and it may help 1/5 of our patients, but at least let that 1/5 have the benefit. In conclusion, many discoveries are made by individual human minds. And the credit is taken by big corporations like Google, whatever. But the actual discoveries are done by one person. And we need to help our patients with whatever tools we have at our disposal at this point of time. You can't tell there is no proof on this, there is no proof on that. If we find it is useful and it is helpful, and as long as there is no major side effect, I think we should be able to use it. Thank you very much for patient listening. Thank you.
Hello. Yeah, thank you so much, Dr. Anand, for your comprehensive talk. Now I'll request Dr. Monish to please moderate the session. Yeah.
Thank you very much, sir. I mean, indeed, it was a pleasure hearing you. We all know you as somebody who is very innovative, when it comes to any aspect of ENT, it is pathology, laryngology, or rhinology. Interesting concepts indeed. And I have heard you earlier talk about the tympanomeatal flap being elevated for inner ear drug delivery. Now, a few things which came to my mind when I was hearing. One is we all probably have seen increase in cases when it comes to post-COVID sudden SNHL. Now, is your treatment plan any different for these set of patients?
Should be the same, as long as they are RT-PCR negative.
Right. So you will not like to do anything if they are RT-PCR positive, or you can still go ahead with an
No, if they are RT-PCR positive, you take all precautions. But if it is just 2-3 days of sudden SN loss, I think we have to take precautions and do it.
Perfect enough.
But the problem in COVID positive in an ENT hospital.
Yeah. Right. And you mentioned about intratympanic steroid being used for sudden SNHL.
Yes.
Do you use it in combination with oral steroids, or it's always only intratympanic?
Mostly I give it only intratympanic. I don't give oral.
Okay. And
because I believe that direct delivery.
Yeah, and you mentioned about 10 days thing. There are few papers which mention salvage therapy coming into place. Do you think that
is, I told you, hyperbaric oxygen.
No, salvage therapy means, I mean, in the sense that even after 1 month, if you give these oral and intratympanic combinations, they may work.
See, Manish, we don't know whether our therapy is bringing it up or self-recovery of cochlea. We don't know. But see, there are patients like our own doctor colleagues who insisted, and I have done it. Some have done well, but they are on anecdotal. There are only some 4 or 5 patients like that. I can't base statements on that.
So now let me questions which have come through our online this thing. Dr. Charuhas Jagtap from Dhule, right? He's asking about your when you mentioned acyclovir in Meniere's disease.
Yes.
It really effective, and he also mentions the recent MRI studies with contrast suggesting that drugs are absorbed more through the oval window. Your viewpoint on that? Interesting, actually.
Yeah, I'm not very sure your MRI is so good. They can't even find out the diameter of coronary arteries with MRI. I don't think they are so precise, but companies will bring out these articles to sell more 6 Tesla MRI. I'll be very skeptical about it.
But
this MRI
the oval windows, he mentioned specifically the oval window. Do you believe in that?
I'm not sure. I think studies are the see what I'm trying to base on. Like we have been doing this for about more than 15 years. So the experience is for a long time. And if my resident is going to put some gel foam into the inner ear when I'm not in theater, I'd rather ask them to put it in round window than oval window, except in cases where you think it's a high jugular bulb. Incidentally, that's one of the complications. We have had a jugular bulb leak during this kind of procedure. Yes.
A feature which can happen in any middle ear surgery if you're doing.
Can you be ready with your medicines to block it?
Yeah. Now, Dr. Ramesh Rohiwal sir is asking any experience of carbogen therapy for sudden SNHL.
Yeah, I think there is a role.
And do you?
No, I don't practice it, but definitely there is a role.
Right. There is a question by Dr. Arijit Chakravarti from New Delhi. Do you have a comparative study with oral and IT steroids in your patient with sudden SHL, considering the risk of infection? do you think there's a risk of
Oh
infection?
no. You see, I should have put one more video because in sudden SN, when you want to put Dexona, you put a gel foam, the smallest gel foam you can pick up with a curved pick. That is just enough to stuff into the round window. Okay, like how you put a ear plug, like that you stuff the round window and then put a few drops. It will just bulge out, but it will never reach the eardrum. So I don't think that is going to lead to any infection. But if you are going to pack the middle ear, yes. You pack the middle ear with steroid, your drum will first get thin and may get even perforated. So you are talking about Dexona in middle ear means only with a very small piece of gel foam pressed into the round window like a button, not just kept on the round window. Did I answer the question? And I will not put any antibiotic when you are doing for sudden SN, because we know most of the antibiotics are toxic. We have considered using tetracycline because that is non-autotoxic, but then we don't know how it will interfere with the Dexona absorption. So but most of these sudden SN patients with Dexona, we give oral antibiotics. Whereas gentamicin patients, we don't give oral antibiotics.
So wonderful. Yes, sir.
Monish, Dr. Kirtane here. I think there are questions also from the different centers.
I was just about to say that.
Bangalore, Kolkata, Guwahati.
Now Kolkata 2, please ask your question. Kolkata 2.
Hello, sir. This is Professor Arunabha Sengupta from Kolkata.
Yes, sir.
Question. There are 3 questions from Kolkata. Professor Somnath Shah has asked, what is the role of Kenacort in sudden sensorineural deafness? Number 1. Number 2, when you will use gentamicin and when Dexona in Meniere's disease? And how you are going to treat tumakin otolith crisis, repeated drop attack? These are the 3 questions which I am asking to.
Shall I start answering? See, let me start answering. You asked whether Kenacort can be used. No, it cannot be used in this situation. It can be used as an injection on a polypoid middle ear mucosa in polypoid CSOM during surgery, but not for ITT. I have not tried it. I use it for polypoid mucosa of the CSOM. 1. Second is you want to know when to mix Dexona and Genta. In a known case of Meniere's, if there is a sudden loss in hearing, then the Dexona I'm using for the sudden hearing loss, Meniere and Genta for the Meniere's. This tumarkin auricular crisis, this big name is meaning drop attack. So I've already told it. Thanks.
Thanks a lot. Thank you.
Now Indore, please ask your question.
Sir, Maru, sir. Hello, I am Dr. Yashwant Maru. Hello.
Yes, sir.
Yes, sir. We can hear you.
I am Dr. Yashwant Maru from Indore. My 2 questions are there. One is in post-COVID, early or delayed tinnitus with mild or moderate, profound or sensorineural deafness unilateral, with or without vertigo, what is your management? Post-COVID,
your question, let me answer. Because it's a post-viral sensory loss, I think one can go in for that acyclovir, the dose which I told you already, for whatever benefit for the virus, you can give that. And second is you use the intratympanic treatment with Dexona. There is no contraindication on that.
See, okay, usually they are mostly severely diabetic cases.
Yeah, ITT with Dexona can be used in severe diabetes unless they are comatose.
See, they are already having mucormycosis sometime.
So why not? Why don't you put some 1 drop of Dexona into the round window? Let him have mucor. Let your colleague treat that mucor in the nose.
The problem is not treatment. Problem is their claim with the government.
That's excellent. That I think you have to solve yourself. That I can't solve you.
No. Reason being, they demand heavy compensation from the government that they are COVID patients and they have suffered this problem after COVID 4 weeks, 6 weeks, 2 months, 3 months. Now, second question, just listen to me. In post-COVID, sudden or delayed tinnitus with herpetic infections near the ear, Ramsay-Hunt syndrome. You know, these are
that is due to the dormant herpes simplex virus in the neurons.
Yeah, I mean, they are 1 out of 100 case, but they do come with the eruptions near the pinna or in extra-aortic canal. They develop first tinnitus, nobody pays attention in the COVID treatment, those physicians who are attending, because they don't refer it to the ENT surgeon. But when they develop hearing loss, and sometimes they develop facial weakness, facial paralysis, I should say unilateral facial paralysis. Now, these cases are shunted from pillar to post.
If you put it in a very simple way, you are talking about post-COVID Ramsay-Hunt syndrome, correct?
Yeah, post-COVID Ramsay-Hunt syndrome.
Treat them like
Anand, if I may just come in here, I think we are going off the point. I don't think you're giving intratympanic injection for Ramsay-Hunt syndrome.
No, sir.
So I think the question should be related to the Marusab, related to intratympanic injection, because with the facial palsy, etc., we're going a little away from the main topic. So if it's something regarding an intratympanic injection, I think we should.
My question was asking, anybody has come across such situation where somebody by mistake has earlier given intratympanic injection?
No, sir, I have not come across.
Okay.
Okay, Chandra.
Hello.
Next.
Yeah, one more question.
I think we have time for just 2 more questions.
This is Dr. Abhik Sikdar from Choitram Hospital, Indore. I'd just like to ask that acyclovir, which is given in these cases, is usually given 800 milligram 5 times a day. But there is a lot of issues regarding patient taking 5 times a day. So I think presently what is being used is Virovir, valacyclovir, which is used 1 gram 3 times a day. Any comments?
No, I think if you have a better molecule, please go ahead, as long as the spectrum is the same.
Actually, it's not only a better molecule, it can be given 2 to 3 times a day, so their patient compliance is better. Because 5 times
can you tell me the correct name, doctor?
So, Virovir. The trade name is Virovir.
Okay, it's made in India?
Yes, sir, very much made in India. VIROVIR, Virovir.
Very good. I think we should try the newer molecule.
So I'm using it since last 4 to 5 years. I have excellent results.
Good.
Okay, go to Bangalore. I think Bangalore has a question.
Ranchi, we are moving to Ranchi. Okay. Ranchi, please ask your question.
Hello, sir.
Yes,
I'm
sir.
Dr. Pradeep from Ranchi, sir. I just wanted to ask you, sir, you stated that intratympanic treatment with carovarin. Sir, where from we get carovarin injections, and what was your sample size so that we can know the exact...
Okay, see, I stopped doing, I was doing around 4 years ago, 3 to 4 years ago. The drug's name is Tinicare. I think it comes from a company in Gujarat. If you send an email, I will send you the details. I can't tell you offhand, but it's definitely a product named Tinicare.
Form, sir. Is it available in injection form, sir?
Yes, it was. I stopped using it. It was an injection, yes.
Carovarin was initially available only in injection form. Later on, they came with the tablets. Yeah.
Excuse me, sir, just one question. In the tinnitus with a normal hearing, is there any role for any intratympanic? Normal hearing tinnitus?
As long as it is sudden, within 2-3 days of onset, you can try.
And say if it is, it comes, because people try the conservative method and it may pass off its own. So suppose if you get after a month or so, patient had continuous intermittent tinnitus with a normal hearing, no other pathology, imaging is all normal.
I don't think I will do ITT for that patient, doctor. It's risky. Because once you do ITT, you are offering a surgical procedure, however small it may be. And I'm not very sure of the result or the outcome.
Thank you, sir. Thank you, sir.
Now, please, Hyderabad, ask your question. Hyderabad, please unmute yourself and then ask. Yeah, continue.
Hello.
Yes,
good morning. Dr. Anand, this is Dr. Ramesh from Hyderabad.
Yes, Ramesh.
See, honestly, suggest us, would you like to try ITS for chronic cases of tinnitus without giddiness?
No, I told you, no. Chronic tinnitus will not respond to these things.
Yes, we have miserable results with that.
So no, please don't do anything longer than 7 days tinnitus. It is just, you can, it's trial and error. And I don't think in the present medico-legal scenario, one should get into that.
So within 1 week, we can try.
Within 1 week of onset.
Yeah, within 1 week onset, we can try that.
Yeah, earlier the better. It is like MVK used to talk about sudden blindness after trauma. He used to say 24 to 48 hours we have to do optic decompression. I think these nerves, they don't live long once they are damaged, or these cells, whatever.
Yeah, now please, Delhi location, please ask your question.
Oh, hello. I'm Dr. Manoj Kumar, Senior Consultant ENT from Delhi.
Yes, Dr. Manoj.
So there are 3 questions that I would like to ask. One is that acyclovir has no proven efficacy against corona. So how it can benefit a post-COVID patient in sensory neural hearing loss?
No, wait. I'll answer it quickly because the other colleague asked herpes zoster, which is manifesting after COVID. Now, COVID is an immunodepressant situation, and the herpes simplex virus in the dormant neurons come up. And for that, your acyclovir works, not against COVID.
Not in a post-COVID case, right? Number 2.
Post-COVID case can get malaria, typhoid, as well as herpes simplex.
That is understood.
So this is for herpes simplex.
My second question is that many years ago, we read in a very standard textbook of ENT that unless it is proved beyond suspicion that the sudden sensory neural hearing loss is not viral in origin, steroids should not be used because it can be counterproductive sometimes. And I'll complete my question quickly. It was suggested that if you suggest the patient to breathe in an envelope to have increased CO2 concentration to improve microvascular circulation, it is more beneficial than anything else. So I have been practicing that. Besides giving paracetamol, that means neutrophil, to my patients, and I have seen a lot of improvement in a lot of patients. So, sir,
true.
I would like to have your take and your experience.
Now, already some center asked about carbogen therapy. That is what you have been practicing. Accepted method of treatment for improving the microvascular circulation. And to add more benefit, you please add hyperbaric oxygen to this, because where the blood vessels don't go, the hyperbaric oxygen will go and save those neurons till the vascular supply is re-established. So if you combine your carbogen with your paracetamol and platelet smoothening agents with HBOT, it will be even beneficial to your patients. Yes.
Anand, thank you very much for a very, very exciting presentation. I'm sure there are many more questions, but I think we have to now move on to the next topic. Anand, if you do not mind, can I give your email ID to the participants so they can write to you? Because your presentation has been very exciting, and I'm sure there are a lot of queries.
Controversial as usual.
Not controversial. I think there is a lot of merit in it, and it may help a lot of patients. So they might want to get more details from you. So what email should they write to you on?
Shall I just tell?
Yeah, sure.
Anand,
go ahead.
ANAND Anand @ ENT Anand.com. Repeat, Anand @ ENT Anand.com. That's it.
Right. Thank you very much. And for those.
We can't hear you, sir.
Was to small. Okay, we go to the next.
Okay. I would like to call upon our next speaker, Dr. Srinivas Kishore from Sisla. And sir is, just a second. Yeah. Sir is an immediate past president of Association of Surgeons for Sleep Apnea, and he has a clinical attachment at Gruppo Otologico Venezia, Italy, 2007. He also has mini fellowship endoscopic sinus surgery from University of Pennsylvania, and deliver his talk on the topic.
Can you hear me?
Yeah, we can. We can hear you.
Yes, sir. Yes.
Okay. Greetings from Hyderabad, everyone. At the outset, my pranams to teacher of teachers, Professor Kirtane. Thank you, Dr. Hathiram, for accepting to moderate this session. And as always, thank you, Alchem, for this wonderful opportunity to bring us all together. Without further ado, let me just start my presentation. Can you see my slides?
Yes, sir. Yes, sir.
Okay. So the topic I'm going to talk to you all today about is tackling tongue-based obstruction. And we're basically broadly going to go about talking about tongue-based obstruction and tackling it when and how. Now, we are all surgeons, and before we do when and how, we need to know why. Why do we need to tackle tongue-based obstruction in obstructive sleep apnea? And in order to understand that, if you really look at this data that's come out of meta-analysis after a lot of DICE papers, you would see that in 84.1% of patients, it's soft tissue obstruction. Almost 50% of obstructions are at the level of tongue base. Now, what does that equate to? It equates to a residual obstruction at the tongue base after you, or if you do a single level surgery, supposing you just do a soft palate procedure for a multi-level obstruction caused by obstructive sleep apnea. And since there are significant obstructions at the level of the tongue base, there will be residual obstructions at the tongue base in about 17 to 33% of the patients. And hence, we need to deal with this very problematic condition, which is tongue-based obstruction. Now, because we have to understand why, let's first start with a paper that's come out in 2007. Now, this paper basically answers a very, very basic question, that why does weight loss work in patients with obstructive sleep apnea when you have just weight loss as a treatment modality? And the paper is titled, "What is the link between obesity and OSA?" So if you look at this image from this paper, 28 to 32% of fat gets deposited in the tongue base. This paper also gives a very interesting graph wherein they've pitted body mass index against percentage of body fat. And solid diamonds are anterior tongue and hollow squares are posterior tongue. And if you keep going, and as the body mass index increases, look where the tongue fat is getting deposited. It's all getting deposited in the tongue base. Now, taking this even further, it's not that simple. Right, here's a very interesting paper from Kim et al., which actually compared apneic subjects and normal subjects and found out that even though in these patients, if BMI is the same, if their AHI is higher, that means if you take an apneic subject and a normal subject and you calculate the tongue volume and percentage of fat, there is a staggering difference in the percentage of fat in a patient with obstructive sleep apnea as opposed to somebody who doesn't have obstructive sleep apnea. So there is something that obstructive sleep apnea is doing as a disease to tongue fat. Now, if you want to understand the philosophy of treatment of tongue-based obstructions in obstructive sleep apnea, we need to basically understand the pathology and phenotype how tongue base is causing obstructions in obstructive sleep apnea. So broadly, you can divide them into 4 types. The easiest to manage will be lingual tonsil hypertrophy, and all of us see that. Macroglossia, retrognathia, hypotonia, and the new kid on the block, what we now call as loss of coupling. And I'm going to talk to you all very briefly about each of these phenotypes and talk to you about when you suspect this particular phenotype and ways and means to treat one of them. Now, when you also need to understand that these phenotypes are not mutually exclusive, sometimes they come in combinations, and that is why tongue-based obstruction management is actually a potpourri of these phenotypes. Now, for us to understand and go further into and deeper into managing tongue-based obstructions, one basic classification that one needs to understand is called the Morse classification, classified by Kent Moore, who's a maxillofacial surgeon. And he basically divides them very simply into A, B, and C, wherein A is upper tongue base, B is upper and lower tongue base, and C is just epiglottic obstructions caused by tongue base. Now, for us to understand why is Morse classification so important? It is important because any kind of an upper tongue base obstruction is associated with poor treatment outcomes. Now, with this understanding, let's go a little deeper. Now, we'll start off with the easiest problem to tackle tongue-based obstruction. These big mounts that most of you can recognize are lingual lingual tonsils, and these are the easiest of the pathologies to address. Michael Friedman divided them into 5 grades, wherein grade 1 is almost scanty or no lingual tonsil at all, to grade 5, wherein the entire valvula is completely obstructed by the lymphoid hyperplasia, and to the extent that one cannot even see the tip of the epiglottis. Now, for grades 1, 2, it's probably a good idea to try conservative management, but from grade 3 and 4, it is better that we try and do this surgically. Surgical management of lingual tonsil is one of the easiest techniques to do. Here you can see the patient is being intubated. We're using coblation to do it. Lingual tonsil hypertrophy excision can be done from the midline. You can use coblation. To me, is one of the easiest tools to do. One trick that I would like to tell you to deal with lingual tonsils is to actually put a pressure bag so that you're almost operating underwater. This way, the amount of plasma that is being generated at the tip is more, so that your ablation is better There are no landmarks here because you're just basically trying to ablate whatever you have in front of you. You can clearly see how easily the vallicula is now developing. On one side, you can see the vallicula, you can see the epiglottis, and here it's completely gone. Try to keep the face of the coblation towards the lymphoid tissue so that, or instead of actually burying the electrodes wherein you're not seeing what you're ablating. This way, you are able to see what you're ablating. And if you are actually coming across any kind of a bleeder, you can actually switch to a higher mode on your coblation, or you can press the blue pedal. Now, this is one of the easiest way of treating tongue-based obstruction. Lingual tonsils are, and these patients can be treated as a single-day outpatient procedure, or you can admit them. But one needs to also understand that this is not a standalone procedure. Usually it's done as a multi-level procedure. Now, once you deal with this kind of a pathology, the next kind of a phenotype is actual macroglossia, wherein macroglossia can be of two kinds. It's acquired macroglossia or it is relative macroglossia, and I'm going to talk to you all about both of these. Now, acquired macroglossia is very typical in patients with high BMI. As you see them in the outpatient, they will have a Mallampati grade of 3 and 4, and we need to understand that uniform enlargement of the oral and pharyngeal tongue. They usually have a huge tongue. And when you look at their dice, you can see that the entire tongue is actually crushing the epiglottis, causing a secondary epiglottic obstruction. And this is how acquired true macroglossia presents. Now, whenever you want to deal with macroglossia, the biggest problem that we are concerned about is the neurovascular bundle. And there is a lot of literature out there, but the first one coming out from Loretino, wherein they speak about how you can avoid the neurovascular bundle. The neurovascular bundle is actually located 2.7 centimeters inferior and lateral to the foramen cecum. So this is the safe area that you can start working on. There are other anatomical markers that can be used as well, but this is the one that I use. Now, how do you actually know? You can't take scales in there. Yes, you can take a scale and measure it, but the easiest way for me to do it is to actually use the tip of my coblation wand, which is about 2 or 2.5 centimeters exactly from the tip of the electrode to the black sheath. Now, different companies have coblation wands nowadays. This measure I'm talking about is about this Smith & Nephew wand, which is usually about 2 to 2.5 centimeters. So this you can actually use to measure from the foramen cecum as to how lateral and how inferior you would like to go. Now, if you want to not be very aggressive in your approach, or you are treating a patient of sort of a mild to moderate obstructive sleep apnea, you can also use multiple radiofrequency inserts, which you can actually plan by putting one insert 1 centimeter in front of the foramen cecum, 1 centimeter in front of the proximal spot that you put in, and one more 1 centimeter in front of the next. The last insert will be 1 centimeter in front of the one that you have done before. So you put in 3 spots and 2 more lateral spots that you can put in. That is 1 centimeter in front of an imaginary line drawn laterally from the foramen cecum and 1 centimeter in front of this. Now, are the results good? Well, somehow only the Chinese have been able to reproduce this good results in this and get good results. To me, this kind of application has not worked wonders, but if you have a patient with mild OSA who's willing to undergo multiple inserts, this can be a procedure that you can adopt. Now, if you have a patient with moderate sleep apnea of about 15 to 30, the kind of procedures that you can do is either an endoscopic procedure called midline glossectomy, or a more conservative procedure, what we now call as submucosal minimally invasive lingual excision. Now, the advantage of this procedure is that you can actually create a submucosal trough and endoscopically guide your wand into this trench. Now, one good thing that would help you is to have some kind of a marking that is done intra-op with an ultrasound guidance. Now, if you can see here, I'm actually putting a lot of pressure, and you can see, but my wand is not touching the muscle tissue below. This is not a blind procedure. And if you are sticking to the landmarks that has been described by Loretino and stay 1.5 centimeters below and 1.5 centimeters on either side of the foramen segment, you are very safe. Now, once you could either suture this entry wound at the end of the procedure, what happens is that this basic tunnel that you've performed would eventually cave in, and you would get a very nice volume reduction. And there's a lot of data to sort of support that. Now, sometimes you may have to do tracheostomies when you have huge tongue bases that you need to excise. Now, please remember, all these techniques we are doing is for absolute macroglossia, wherein the problem is not with the mandible, the problem is with the tongue itself. Now, here is a patient wherein patient had amyloidosis, and then we had to do a major tongue base resection. It is not about doing the procedure. Everybody can do the procedure. The aim of my presentation is for you to understand is to what kind of procedure you would do for what kind of phenotype. Now, there are other modifications of this procedure. There is a procedure that's come out of Taiwan from Ang Lee, not of the Life of Pi fame, but from the obstructive sleep apnea fame, wherein they actually make trenches onto the tongue, and you can actually remove each chunks of tissue and send it. Now, how do we go about and compare it to the great TORS that we are all talking about? Because TORS has been associated to be having great results when it comes to tongue-based excision. So I think we should compare how TORS compares to the kind of procedures that we do in day-to-day practice, which is the tongue-based resection. Now, this is a very nice article wherein the authors compared the efficacy and safety of transoral robotic surgery with endoscopic guided coblation tongue-based resections. So if you carefully look at this data, robotic tongue-based resection with coblator tongue-based resections, if you look at AHIs, 45 to 17, 45 to 16, that means coblation tongue-based resection fared pretty well. If you look at the lowest oxygen saturations, robotic tongue-based resections, again, 79 pre-op lowest saturations to 85 lowest saturations. Pretty improvement in the lowest saturation. Same results were replicated with coblation tongue-based resections as well. So when you are doing coblation tongue-based resections, they're not very inferior to the very expensive coblation tongue-based resections. Now, the synopsis of this particular paper was that in comparison between TORS and coblation, we found that TORS to be as effective as coblation. Now, the use of monopolar bovie, which the robot uses, may induce more postoperative pain than the coblator, which will result in longer postoperative stay. Now, what about the result, right? Because the amount of tongue base that you can remove with using a Da Vinci is significantly higher. So this is a very recent paper from Yasin Bhagat and Ahmed Bhagat, mentees of Claudio Vicini, who pioneered TORS. Here, what they have done is they've actually measured the lingual tonsil that has been excised. So what they've done is remove chunks of this tissue, and they found out that if you have resected more than 10 centimeters square measured in the form of a syringe, in terms of volume, your results are pretty good. So if you use coblation, stick to the principles of transoral robotic surgery, your results are pretty good. What I'm trying to emphasize here is that you needn't have a very expensive tool to get good results in tongue-based surgery. Now, at this point, I would really like to bring in what we now call as the Stanford 2 protocol. Sometimes what happens is, if there are significant dentofacial deformities, you may have to go in for skeletal procedures and what we now call as relative macroglossia. Now, relative macroglossia means the dabba, which has to hold the container and contents concept here. The dabba, which has to hold the atta, is smaller, right? So in such cases, since you can't reduce the size of the tongue in this particular tissue, no matter how much amount of tissue you remove, it's not going to be safe because the problem here is the container. So in such surgeries, in such situations, doing a soft tissue procedure is not right. And these surgeries are called as box surgeries. The commonest of them are called genioglossus advancement. We can also do other procedures called hyoid suspension and maxillomandibular advancement. What is the principle behind genioglossus advancement? Genioglossus is the major dilator. So its activity is very important when you treat obstructive sleep apnea. Please understand that genioglossus advancement is never done as a standalone procedure. A word of caution, about 30% of population, it may be contraindicated due to the short distance between the dental roots and the genioid tubercle, which can result in a possible dental injury, can cause problems. So we need to be very careful, and it's better to do 3D CTs before we do this kind of a procedure. The easiest of these procedures are called slide genioplasty, which you can do by yourself or with the help of your maxillofacial colleagues. If you take a look at these pictures, you would actually see pretty good results at the end of the procedure. So the results can be anywhere between 39 and 78%. Now, why is there such a big spectrum in terms of the result? This is also because of the different indications and the different surgical techniques that one would adapt. So it ultimately boils down to you as a surgeon as to whether you have selected the right procedure for the right patient. Now, I would like to talk to you about the new kid on the block called the loss of coupling. Now, what is this concept? Now, it is important that when you sleep, the tongue should be always in touch with the hard palate. And this is called coupling. When is coupling lost? If there is very less space in the hard palate, there is no space for the tongue to sit in. So where would the tongue go? The tongue would obviously slide back into the oropharynx and hypopharynx, and this concept is called loss of coupling. Now, how do they look? They look like these patients. The moment you open your mouth, you're looking at a high arch palate, and these are not kids. They lived all their lives like this, and they sleep like this. So the minimum diameter between the molars should be above 30 millimeters. If they are below 30 millimeters, and a lot of studies that were done, that if the patient's intermolar distance is less than 30 millimeters, there is loss of coupling and there is no space for the tongue to sit in. This is a dice of a patient in whom there is loss of coupling. If you look at, this is the soft palate, and you can see how the tongue is just falling back. Now, we are doing an intraoral dice for this particular patient. See how the tongue is falling backwards? It's not sitting. And it's not only going down by itself, it's also crushing the soft palate as well. And in these patients, just correcting a soft palate wouldn't suffice. And these patients initially were thought to be having low genioglossus muscle tone, but that's not true. These are the patients who have loss of coupling. And in these patients, we do what is called as a distraction osteogenesis maxillary expansion, wherein we don't go all the way back up to the pterygoid plates. We do a sagittal split, and then we put an implant, a small expander, which the patient can actually move every single day to the extent where the upper teeth, which are the incisors, completely give way. So you're creating space for the tongue to sit in the area, and you're bringing back the coupling to these patients. And a word about upper airway stimulation. Of course, this is in vogue for a very long time now. This is the only US FDA approved device. I would like to play a small video to just talk to you. So this is hypoglossal nerve implant, and their keywords are no mask, no hose, just sleep. Unfortunately, this is not available in India, and these are the only countries that are available. Asia, and in Asia, Japan is the first country, and Australia, which has now got this. Probably in the next 2 years, we may get this in India. Is this the solution for all our problems? Not really. Again, I would like to emphasize the point that you need to understand the phenotype to select the right procedure. There are other techniques that are also coming out. These are not US FDA approved, but a lot of trials are there. But one needs to understand that the future is all about implants and pacing and these kind of things. But is this the solution for all the problems? No, it is not. If you still have a small jaw, if you pace the tongue, it will start coming out like how a frog would like to bring out the tongue to get its food, and it's obviously going to be disastrous. Thank you very much for your kind attention.
Thank you, Dr. Kishore, for an excellent lecture, making a very complex topic quite simple for us to understand. Just one question from the chat box. How do you measure the amount of tongue tissue volume to be removed by coblation? How do you decide on that?
So basically, what we need to understand is that we need to do this only for patients with absolute macroglossia, point number one. Point number two, if you basically see a massive tongue base obstruction on drug-induced sleep endoscopy, and if you think that this is a patient of muscular tongue base obstruction, you can actually measure the volume by making a midline incision from the foramen cecum up to the median glossoepiglottic ligament, going laterally up to the lateral or the pharyngoepiglottic ligament, and taking out a chunk. And like I showed in that particular paper, you can actually measure the volume in a syringe. And once you measure that in a syringe, based on the displacement of the water or the saline that's come out, we can see how much of volume you have removed. And any kind of a resection above 8 to 10 centimeters cube is a good enough resection.
Thank you. I think we can take questions from the audience, from the various centers.
Bangalore, please ask question.
Yeah. Hello. Hello.
Yes, sir. We can hear you, sir. Yeah, continue, sir.
There are two questions from Dr. Lakshmi Satish. Number one is, how do you manage a sleep apnea patient secondary to large lingual thyroid?
Dr. Lakshmi, thank you very much for your question. If it is secondary to lingual, OSA secondary to lingual thyroid, you would manage it like any other lingual thyroid. You can either use an external approach or you can use an endoscopic approach. You can either use transoral robotic surgery or you can use coblation to excise the lingual tonsil. But we need to be very careful before you take it out. Make sure that you've done a thyroid scan and make sure you're not removing the only functioning thyroid tissue.
The second question is it necessary to do tracheostomy for all patients?
Not necessarily. It basically depends on the how much amount of tissue you're basically, again, it boils down to phenotypes. You know, if you are doing a procedure, a huge tongue-based resection, like in one of the videos that I showed, only in such cases, if you are anticipating any kind of Pope syndrome, that is post-extubation pulmonary edema, then yes, otherwise, no. If the patient has bad pre-existing comorbidities, like if the patient has a lot of CO2 retention, if you think that the patient has uncontrolled hypertension, in such patients, it's probably a good idea to do a trach. Otherwise, no.
Thank you.
Now, Guwahati, please ask a question. Guwahati? Okay, so we are moving Kolkata 4. Kolkata 4, please ask a question. Please, yeah.
Can you hear me now? Yeah.
Yes, sir. Yes, sir. We can hear you.
Good afternoon. This is Dr. Chakraborty from Kolkata. First of all, brilliant presentation and very informative by Dr. Kishore. Thank you so much. Just a very quick question. Your comments on the post-operative management, what do you do? Do this after a tongue-based procedure? Do these patients have a lot of pain? Any secondary hemorrhage? Do you do anything special? Your comments on that.
Thank you very much for your. Can you hear me?
Yeah, very clearly.
Sir, yes, sir.
Thank you very much for that question. So basically, if you are, everything starts pre-op, right? If you have a massive tongue-based resection to start with, the biggest problem that you are scared of are two things. One, is this patient going to blow up in terms of post-op edema? Or two, is this patient going to have any kind of post-operative bleed? Number one, to reduce post-operative edema, one, if you're using coblation, because there is very less collateral damage, you probably will not have too much of post-operative edema. But yet, you are taking out a chunk of tissue. So pre-op, it's good to give about 8 milligrams of dexamethasone pre-op, number one. Number two, if you are dealing with a lingual tonsil ablation, it's highly unlikely that you will have a bleed post-op. But if you are doing a massive muscular tongue-based obstruction, you probably may have bleeding from any of the muscular arteries. It is possible. Now, in order to prevent that, one, you could give these patients good post-operative oral hygiene. I give these patients diluted hydrogen peroxide, and they do it judiciously, and this is very good. And always give some amount of gram-negative cover because you're obviously operating in the post-operative period. The other very pertinent question that you asked was, how much is the pain? To be very honest, the pain, if you do any kind of submucosal procedure, is not much. But if you do a massive midline excision, the pain is there, but you treat them with some kind of very, very potent sort of painkillers. You can, but be very cautious when you use NSAIDs because most of these have antiplatelet activity. So it's better to stick to drugs like paracetamol. Be very careful when you use opioids like tramadol or fentanyl.
Now, please ask a question by Kolkata 2.
Hello.
Yes, sir. We can hear you, sir. Continue.
Hello, Srinivas.
Yeah, Dipankar, I can hear you.
Yeah. So my question to you is a very fundamental question. What is the prevalence of tongue-based obstruction in your practice or in our sleep apnea surgical practice? Number one question, that means in amongst what percentage of patient we would expect that this patient might have tongue-based obstruction and we should address that. Number one. And number two is fundamental, very basic question, whether you will go for multi-stage or single-stage multi-level along with palate.
So the answer to the first question is it's about 30% of my patients do have tongue-based obstructions. Again, in that 30%, some of them are lingual tonsils, some of them are muscular tongue-based. And I am not talking about skeletal patients. I'm only talking about pure macroglossia patients. So the answer to your next question is, whether you do it single stage or multi-stage depends on the setup that one is in. Number two, the patient's preferences and the risk-taking appetite of you and the patient. And of course, if you have a setup that you think you can manage these patients HDU and can manage and have the infrastructure to deal with any kind of a calamity that may arise as a result or as a complication of these kind of procedures, it is probably a good idea to stage them. But the caveat amongst all this is obstructive sleep apnea is a condition caused by multi-level obstruction. And if the disease burden measured by obstructive sleep apnea and AHI is supposing 60, nobody really knows that amongst that 60, maybe 15 is caused by tongue base, 15 is caused by lateral pharyngeal wall, and 15 is caused by soft palate. So if you don't address all the levels of this at the same time, you probably will not do justice to the patient. Exactly. Because if you have just operated on the soft palate and lateral pharyngeal wall, what will happen to the AHI? How much will the AHI reduce? How much of the disease burden will reduce? So you'll really have to pit against the risk versus benefit in terms of the patient's risk-taking appetite, your risk-taking appetite, and the patient preference in terms of how much time he can give us to reduce the disease, and also the kind of the infrastructure you have in the hospital.
Now please ask a question by Kolkata 3.
Okay. Good morning, Dr. Srinivas. There is a question from the audience. What is the importance of intraoperative ultrasound to delineate the lingual artery during resection of the base of the tongue?
So, one, it's not very practical, even though some of my colleagues have done that. To sort of replicate it on a regular basis, I find it very difficult. I find it easier to go by anatomical landmarks and things that have come out after. So I was talking to you about the dissection results of Loretino, which has been published way back in early 2000, wherein they have dissected about 60 patients and they have come out with these particular numbers. So what happens is if you stick to these particular parameters and you can draw them yourself and stick to your anatomical guidelines that have been given, it is very seldom that you come across. It's not very easy to come and hit the neurovascular pedicle when you do tongue-based resections. Tongue-based surgery is not that big of a ghost or a tiger that it appears to be. It is not. If you stick to protocols and if you stick to anatomy, you will not come across these particular neurovascular bundles that we are all scared of.
Yeah, Rachi, please ask your question.
Good evening, Mr. Kishore. I am Prakash Munka from Bokaro, Ranchi. It's always pleasure to be with you. Part of my question you have already answered. In a say multi-level obstruction, how you prioritize which to go?
So, and when you talk about multi-level obstruction, sir, in order to identify what are the structures that are causing the obstruction, we always perform what is called as a drug-induced sleep endoscopy. And on drug-induced sleep endoscopy, we do find that there is an obstruction, say, at the level of soft palate and at the level of the tongue base. Like I said earlier, it is important that you address every single level because it is a multi-level obstruction. So if you only address one level and you allow the other level to progress and cause further deterioration in the respiratory indices, it's like the disease has already taken over and taken off and you're trying to play catch up. If you want to catch that particular disease, it becomes very difficult if you keep staging it because the disease will always have the advantage of taking off early. So I would always advocate a protocol wherein I would like to address as much as possible the obstructions in the same sitting.
Now, Hyderabad, please ask your question.
Good afternoon, everybody. I'm Dr. Dwaraknath Reddy from Hyderabad. Nice to see all you guys from here. And as there is no question from the audience because they're very attentive of what the senior has told, but there is a question from my side. And as you have mentioned about the multi-level obstruction, I'm sure the approach also has to be for all these concerns about the multi-level only. But how far, because this topic is about the tongue-based issues, is it purely sometimes you get, what is the percentage of thing of tongue-based issues you do get apart from taking care of tongue-based issues along with other issues also? Sino?
Sir, good afternoon. So tongue-based basically in my practice constitutes about 30% of the patient load. And we need to understand that tongue-based obstructions as an isolated obstruction doesn't happen very often. Very rarely it happens, like how Dr. Lakshmi asked, in a case of probably a lingual tonsil, or if there is some kind of a lesion in the tongue base which is causing a problem. These need to be identified, and you need to phenotype these patients, why this particular condition is happening. Once you identify the particular phenotype, management is very simple.
Yeah, now Kolkata 1, please ask your question.
Good afternoon, Dr. Srinivasan, for brilliant congratulations for brilliant presentation. I'm Dr. Tushar Kantigos. I just want to know from your experience. This is not a question. So, how much percentage or patient you face problem after multi-level surgery during recovery of anesthesia, ICCU shifting, this type of problem after multi-level surgery?
Tushar, thanks for that question. So again, it's all about working up this particular patient. If you think this patient is a patient with a lot of comorbidities, having a lot of CO2 retention, and that is why doing an ABG for these patients before procedure is also very pivotal, number one. Because if you are doing a multi-level surgery, and if there is a lot of CO2 retention in these patients that is bent up in these syndromic patients for a very long time, they may pose problems in the postoperative period. We should also understand that there is a condition called REM rebound, wherein immediate postoperative period, these patients may develop rebound of REM sleep, which may cause obstructions again in the postoperative period. And if there is a patient of uncontrolled hypertension, if the patient has rebound blood pressure in the postoperative period, you can have problems. But this seldom happens, because if you take, if you sort of identify your patients and plan them properly, a very simple trick that would help us to bypass all these things, especially post-op edema and post-op tongue place collapse or rebound REM, is if you put in a simple nasopharyngeal airway and bypass all these things can be taken care of. If you put a simple oral airway, you can actually take care of these patients. And please remember not to extubate these patients until all the neuromuscular blockage is reversed. Normally what happens in most of our patients is because the anesthetist is in a rush or they want to bring in the next patient, while the complete reversal of neuromuscular blockage is done, they extubate. And these patients, especially with obstructive sleep apnea, tend to have delayed recoveries. And these are the patients that would have problems. Otherwise, if you plan your procedure properly, understand your patient's comorbidities well, these things don't happen.
One last question.
From Pune. Pune, please ask your question.
So there are two.
One question.
One is, if you want to if you are staging the procedures, what will be the gap between your nose job and the palatal job or the tongue job?
Good afternoon, Dr. Gauri. How are you?
Wonderful presentation, Dr. Kishore.
So if you are doing a nasal procedure first, what I would like to understand is how much improvement the patient has got subjectively, and two, how much the the nasal procedure has done objectively. It's very important that we get these two things. Subjectively, you can use any of the quality of life questionnaires to look at the improvement. But objectively, you need to do some kind of sleep study just to understand how much your isolated nasal procedure has improved the respiratory parameters. That would basically give me the idea as to how early I should plan the procedure for these patients. It can be anywhere between 3 weeks to a month or 2 months or 3 months.
So do you do sleep study?
Gauri,
Yes.
we are almost running out of time, and I think Bacci has some more questions which have come in from the net.
No problem.
So sorry about that, but we've already gone over the time. But
Just
Bacci,
one, yes, sir. Just one last question. Somebody has asked, can you compare DICE with Muller's maneuver?
Yes, there is literature that actually said that you can compare DICE with Muller's maneuver, but one needs to understand that the behavior of the upper airway during sleep, whether it is drug-induced sleep or natural sleep, is not the same as when you have an awake patient. So I would say that your treatment choices and your treatment outcomes will totally change once you analyze the airway during sleep. So would I use an Muller's maneuver to decide what procedure that I would like to do for my patient? The answer is no.
Okay. And last question, is there any role of myofunctional therapy before you offer any tongue-based procedure? This is from Abu Dhabi, so we have a lot of audience from everywhere.
Brilliant question, and I couldn't take that into my presentation. There's a huge interest now on what we call as MFT or myofunctional therapy, wherein there are exercises. There is a myofunctional training academy that is now available, and in fact, myofunctional training is made almost mandatory for all patients of OSA, especially children post-adenotonsillectomy. So there is a huge interest on myofunctional therapy. The simple answer to that is yes. It is a very value-added tool in your treatment armamentarium.
Thank you. Thank you so much.
Thank you very much. I think next time when we organize such a program, we'll have 15 minutes for the talk and 30 minutes for the question answers. It's really heartwarming to see so many people taking interest. I'm really apologizing to those people whose questions couldn't be taken. But please try and understand that we have to move forward to the next topic. Next time, when we plan, we'll definitely have more time for the questions.
So we have an excellent choice of speakers and an excellent choice of topics.
And the moderators too. Thank you very much. Okay, Srinivas, thank you very much. And I think we'll just move on to the
Thank you, sir. Thank you very much.
Yes, thank you for the session, for the wonderful session. Okay, you have to. On to our next session on the inside out of inverted papilloma, and I would like to introduce and welcome our next speaker, Dr. Gaurav Medicari. Sir is a consultant rhinologist at Medicari Super Specialty ENT Center and also a program director at Skull-Base Unit HCG Group of Hospitals. He has got the fellowship in rhinology and anterior skull-base surgery, Vancouver, Canada, as well as the fellowship in rhinology and skull-base surgery at Liverpool, UK. Sir has fellowships in rhinoplasty as well as facial cosmetic surgery and Shimian Rhinoplasty Clinic, Seoul, Korea as well. Welcome, sir. And I would also like to introduce our moderator for the session, Dr. Renuka Brado. And ma'am is here with us right now. As we know, ma'am is ENT HOD as well as a very senior consultant in Mumbai with LTMMC Hospital. And she is an internationally acknowledged expert in the field of endoscopic sinus skull-base surgery. Her special interest and focus of research is tumor called juvenile nasopharyngeal angiofibroma, and she was the first surgeon in India, amongst the first in the world as well, to undertake the endoscopic excision of this tumor. And her work in the field over the last 18 years has culminated in one of the largest international series for this rare tumor. So I welcome ma'am to moderate the session. And I also request Dr. Sameer Guliani from Alchem to felicitate ma'am with a bouquet. Ma'am, please, I'll welcome you on the stage. Welcome, ma'am. And now I would request our speaker, Dr. Gaurav, to share his screen and start the session. Thank you, sir.
Hello, just a minute. Gaurav, I'm going to take a few minutes before you start your presentation.
Sure.
So I have a very pleasant duty here, and that is that Dr. Subir Jain has come up with 2 books on allergic rhinitis, which he is going to release today at the hands of Dr. Kirtane. The foreword for these books has been written by Kirtane sir himself, and there are 17,300 copies already distributed in the last 6 months, and they're expecting another 16,000 copies ordered shortly. And it would be helpful not just for the ENT specialists, but chest, pediatrics, family physicians, PGs, and undergrad students. And the other book is in Hindi, Naak Ki Allergy, which is written specifically for patient awareness and general public awareness. And this is completely free of cost. So congratulations, Dr. Jain, on this wonderful work. So we will go on with the next session, and Gaurav, all yours.
Thank you. First of all, I would like to take this opportunity to thank some of the most crucial people in my life. First of all, Dr. Milind Kirtane as well, who has given me this opportunity, and not only this one, but many more of them in the past as well, to showcase my work in front of such a lovely audience. Secondly, I think I would like to thank Dr. Renuka Brado as well. I've said this many times before, but she's one of the most important inspirations for me to actually even think that we could practice rhinology as a standalone career, and actually do well in it as well. So thank you so much, ma'am, for giving me that inspiration. And third of all, my father. Without him, I don't think there would be much of me, for allowing me to pursue my career path, which is actually much, much different from what his is. And giving me that freedom to go forward. Thank you so much. And this is a very auspicious day as well, because it's Teachers' Day. Thank you to all those countless teachers who actually have taught me and supported me and allowed me to reach this stage at which I am. So without further ado, I would like to introduce my topic, inverted papilloma. So this is a picture that was shot by me. It's a spider inside of a rose. The reason why I actually sort of relate with this with inverted papilloma is every time I would try to go closer to take a picture of the spider, it used to go into these crevices or petals within the roses, and I had to wait for hours together to get the shot. Inverted papilloma is somewhat similar, where the tumor actually grows inwards and it starts growing into the bone. And there is a very high chance of recurrence if we do not address this tumor correctly. So based on my experience from August 2016 to now, what I have seen is that I've documented about 46 cases. This is actually a little old data. This is probably about a year old. I have to update it, but I have been a bit lazy to do it. So of these, about 2/3 of them were primary cases, and about 1/3 were actually revision cases, with a mean age about 63 years, female to male, male to female ratio about 2:1. 25 of these were smokers presently or have previously been smokers, and we found dysplasia in about 4 cases. And depending on the location, the most common location, as literature says, is actually the medial wall of maxilla, with lateral wall maxilla being second and posterior end of septum being the third. Very rarely I've seen anterior wall of maxilla being involved. just probably in about one case. So the problems which are associated with inverted papilloma are multiple. Just to name a few, we have primary issue is actually sinus and nasal obstruction, which also leads to mucus trapping and possible formation of a mucus seal or even fungal involvement as well. There is bone destruction in certain cases, or bone remodeling, I would like to say. Usually this tumor is locally aggressive. There is possibility of orbital or intracranial extension, which is again associated with a higher recurrence rate, makes it much more difficult to operate as well. Recurrence or residual of tumor, again, it's a problem because the patient has to undergo multiple procedures if it's not done correctly, and there is always a risk of malignant change. We're going to discuss all these issues one by one. So if you look at this study which was done by Tamaki, we find that there are two common issues that are seen which are associated with malignant transformation of inverted papilloma. So if you go by the history, you'll find that nasal bleeding has got a high association with either dysplasia or malignant transformation of the tumor. And on a CT scan, if you see bony destruction, again, it goes in favor of malignant transformation of inverted papilloma. We have a Krauss staging system, which was actually devised by John Krauss, where they categorize into 4 categories for this tumor depending on the extent of the tumor. Without going into further detail, I would like to tell you that Krauss classification only helps to plan the approach for the tumor, but there is no association of this classification system with recurrence or malignant transformation, which makes it not very useful for us. So this is a systematic review and meta-analysis which has been done, where they took hundreds of cases or hundreds of studies, and then they actually collaborated that data, and they found that there is no significant clinical correlation with this classification system and the chance of recurrence. So that makes it difficult for us to use it. They also found that using an endoscopic approach is associated with 44% of reduced risk of recurrence when compared with an open approach, because clearly today the kind of instruments that we have, endoscopes, the debriders, the drills, and all the other equipment that we have, obviously we can give a much better result in these cases. So this is another meta-analysis by Quant. I've actually stuck most of my evidence-based research on meta-analysis because that's the highest level of evidence we have. So we can actually incorporate this straight away into clinical practice, and this is of significance so that you guys can also take these points home as well and apply it into clinical practice. So they found that if you use in a Krauss stage 1, the risk of recurrence is reduced by 45% when an endoscopic approach is used. Whereas in a stage 4, an endoscopic approach actually increased the risk of recurrence by 92%. So so this goes to show that recurrence doesn't depend only on the operative approach, but it also depends on the site and origin of the tumor, as well as the site of attachment, origin, and the size of the tumor as well. Where it also goes to show that areas which are more difficult to reach have higher chance of recurrence, which is but obvious because there's going to be incomplete removal of tumor, or you might leave behind some tumor as well, especially in the bone. So there is another classification system which is histopathological, where they have stages 1 and 2 for benign, stage 3 is dysplastic, and stage 4 is malignant transformation. The latest classification system, which has been devised after a systematic review of about 445 cases, is the one which is by Martin Citardi, where they've classified it into 3 categories depending on the recurrence rate. Now, this is actually much more useful for us because in the long-term follow-up, usually we follow up inverted papilloma for 5 years. We treat it like any other malignancy. After 5 years, it's up to the patient if they want to follow up. Usually, I recommend once a year that they come and see us. So here we have 3 categories: those which are involving nasal cavity or the medial wall of maxilla or the ethmoid sinuses. The chance of recurrence is very low, so you can classify it as stage 1. Whereas if it is involving any other wall of maxilla, it could be posterior, lateral, or anterior wall, or the frontal sinus or sphenoid, then it becomes class 2 because this has got a higher chance of recurrence. And if it is extending beyond the paranasal sinuses, then the chance of recurrence is much higher. And this is classified as stage 3 tumor. So this is a study, again, very interesting, where they studied the clinical behavior of the papilloma with the cellular dysplasia. And they found that patients who underwent open surgery, even in dysplastic cases, had much higher chance of recurrence, as well as those patients who had dysplasia to begin with have a much higher chance of recurrence. So these are the two risk factors that we could study. Now coming to the imaging, this is a beautiful paper which is written by Raymond Chung. So they have studied CT as well as MR images in inverted papillomas. And they say that CT is a very good method. Usually both are complementary to each other, but if you had to do one, I would recommend doing a CT as a baseline evaluation for these cases. So on CT, you can actually identify the site of attachment of the tumor. And normally you will also see signs of bony remodeling, like thinning and bowing of the bone, or even sclerotic changes in the bone, as if you oppose it to osseous destruction, which is more commonly seen in a malignancy. So there are two types of focal hyperostosis which are seen. One is a cone-shaped hyperostosis, and second is a plaque-like hyperostosis. So we're going to just see some examples of these two. If you see this, this is a CT scan where the tumor was involving the medial wall of the maxilla. You can see a cone-like hyperostosis in these two areas actually. One is the infraorbital area, as well as one is in this upper part of the medial wall of maxilla. And the same thing correlates on the axial section as well. If you clearly see the type of bone we have here along the anterior wall and lateral wall of maxilla, and look at what we have on the medial wall, there is definitely some amount of sclerotic changes which have happened in this. So this gives you a hint that this is probable site of attachment. In the second scan, here we see a plaque-like hyperostosis. The first two images are basically soft tissue cuts, whereas the third image is a bone cut. So you can see very clearly this is the point of attachment of the inverted papilloma. Site of origin probably is the ethmoidal air cell, and the adjoining lamina papyracea is also thickened. If you compare it with this side lamina papyracea, this side looks a lot more thickened. That is probably because from this piece of bone, you have a centrifugal growth of this inverted papilloma. Now compare it, this part, just going to use a marker here just to, so if you compare, see this part here is where probably the tumor ends. Now what is happening here, if you look at the bone cut, you will not be able to identify this distinction here. So this is probably, whatever you're seeing here is actually secondary mucus collection or mucus stasis, which has happened because of obstruction to the sinus. So this needs to be differentiated. Now you can do this differentiation much better on an MRI. So MRI with T2 weighted images or a T1 contrast with fat separation will give you fantastic resolution to identify whether or not this is mucus or this is tumor per se, but you will not get a good bony information on the MR. So if at all you want to identify the site of attachment on an MR, you will have to look for loss of or a signal flow void in that area. That will probably give you a hint. So that's why I said both of them are complementary to each other. So when do we do an MRI? If you want to differentiate between sinus involvement by the tumor, or if you want to see if there is any obstructive changes, if the patient has got extensive disease, especially if it is extending beyond the sinus, like it's going into the orbit or into the skull base, you want to get an MRI because you want to see whether the periorbita is involved or not. You want to see whether dura is involved or not. And usually it will appear hyperintense on T2 when compared to muscle. And there's the most classical feature that you will see is a cerebriform pattern. Now this is also seen on malignancies actually. So if you have a doubt, you have to utilize both these features. That is, you will see osseous remodeling on CT with a convoluted cerebriform pattern on MRI goes in favor of inverted papilloma. If you have bone destruction on CT, extensive bone destruction and tissue infiltration, and you have a cerebriform pattern on MRI, it goes more in favor of malignancy or malignant transformation of a pre-existing inverted papilloma. So this is a classical cerebriform pattern where you see alternate dark and light bands. That is called as a convoluted cerebriform pattern because pretty much looks like a brain. If you actually just cut this sinus part out, you will actually see that it looks like just this part. So this looks like brain if you look at it very closely. So that is what cerebriform looks like. One second, I want to So we are coming to the videos now. This is the basic or most common type of inverted papilloma that you will see. So which is the medial wall of maxillary sinus. So now this was a case which I had done probably 2 years after my master's. So there's a lot of difference in the way I operate now compared to how I used to operate before. So you just got a glimpse of the tumor. I would like to also add before we start this video is that of all the things that you have, endoscopic examination is the most important thing. If you're not sure, do a proper decongestion. I have seen a lot of cases come to me where they say that it's actually a polyp, but when I do an endoscopy, there is clear-cut evidence that it's actually an inverted papilloma. So we don't operate on images, we operate on the patient per se. So you have to do a endoscopy in all of these patients. So here you're seeing that I'm actually elevating the lateral wall of the nose or the medial wall of maxilla, the mucosa over it. And I'm actually drilling away right from the start to sort of expose the mucosal lining of the medial wall of maxilla. So you will eventually encounter the nasolacrimal duct as well. That is the hint that you've reached the nasolacrimal duct where you start seeing an arch. So just behind that, you will actually find the nasolacrimal duct. Now I've opened up into the maxillary sinus. I've kept the mucosa intact, and I'm also elevating the mucosa off of the medial side of the medial wall of maxilla. So that is the NLD that I'm touching right now. And behind that, we have the uncinate process. So you can actually very well identify that the uncinate, as the lower down you go, it is so close to the nasolacrimal duct. The higher up you are, it is so close to the nasolacrimal duct compared to lower down where it's little farther away. So especially the horizontal part, it's the safest part to open up when you do a middle meatal antrostomy. So after drilling down this bone, as and when we go, now I'm actually separating the floor of the mucosa of the medial wall from that of the floor. So we want to create a flap on the floor so that we can actually reposition it onto the medial wall when we drill it out completely. So here, I just want to show you a glimpse of the tumor inside of that mucosa. What I'm actually trying to attempt here is I want to remove this tumor in its entirety along with the maxillary sinus mucosa, like, a tumor in a gunny bag sort of, if you can imagine that. So I'm actually elevating the mucosa off of the roof of the maxillary sinus now to the best possible extent that you can, and always make sure that you have good exposure. Don't be in a hurry to remove the tumor. I have seen a lot of people, what they do is they just take a debrider and go in and remove most of the tumor to begin with because they don't have a lot of patience. If we do that, that's one way of doing it. Like Dr. Anand said that there's multiple ways to reach Rome. But here the issue why I like to remove the tumor in toto always is, one is it's good practice for me when I'm doing cancer cases. And second thing is, if there is any evidence of dysplasia in one part of the tumor, I will not miss it because I'm going to send the whole sample for histopathology. And that way I know whether or not I need to keep a close watch on this patient, and I'm going to categorize this patient as a red zone case, which means I need to keep an eye very closely on this patient. So that's the bone of uncinate process that we're removing. And now I'm trying to create my vertical margin and sort of separate this wall, this mucosa on the medial wall of the ethmoid sinus and cutting it with a good wide margin. Now, once I've done that, I've actually freed most of the flap. Now it's just along the posterior part of the nasal cavity above the choana, that is, and onto the septum. Now that I've released most of the medial part, now I'm coming into the maxillary sinus. So here you can see I'm actually struggling a little bit with releasing this from the anterior inferior part of the floor of maxillary sinus. So the reason that is happening is because I've left this small buttress of bone. And I'm actually glad that Dr. Brado is watching, because we always try to preserve this anterior buttress. This is not the anterior buttress, but whatever is here in this part. Usually we don't want to remove that conical projection which comes at the pyriform aperture. The reason being that this is a benign tumor. You don't want to leave a depression in the patient's face. If you remove the anterior wall of maxilla or the anterior medial part of wall of maxilla, they will have a depression which will present after about 6 months to a year, because there is no tissue to support that part of the skin and fascia. So now with that, I've actually elevated all the way posteriorly up to the point where I reach the sphenopalatine foramen. That is the sphenopalatine foramen, as you can see. So I just use a bipolar and coagulate that. And you can now see that I've not had significant amount of bleeding in this case because I've gone around the tumor. Rather than go through the tumor, I've gone around the tumor, and I've not even touched the tumor as of yet because it's inside the gunny bag of the maxillary sinus mucosa. So now it is all about just separating this from the posterior end of the inferior turbinate and just taking the whole specimen out in one go. So there is certain branches which are bleeding, and this is the whole specimen coming out in one piece. So now when we send this for testing, you will know that if there is any dysplasia or any carcinoma in situ, and you know that this is the place that I need to follow up the patient. So that is the the way it looks after removing the whole tumor in toto. I usually just drill it down and flush it down with the floor of the sinus, and then just reposition the flap. So here you can also see the branches of greater palatine artery going into the greater palatine canal as well. Usually I don't like to take off that blood supply because it supplies the bone of the palate. We don't want to have an avascular area there. So I just place some Surgicel and to attain hemostasis. That was a time when I used to pack, but now I don't pack. This is a 4-year follow-up of the patient. So you can see that it is very well mucosalized. There is no, and there is some amount of nasalization of the maxillary sinus as well. That is the nasolacrimal duct sac. DCR also was done in this specific case. So that is the maxillary sinus, which is almost nasalized. So this is good, then allows us to also keep an eye on this patient very easily without having to resort to CT scan or MRI every now and then. Because we don't have the facility or the infrastructure to do that on a regular basis, or the cost will not be very prudent to do that for the patient as well, considering costs. Now coming to lateral wall of maxilla. So this is a 40-year-old guy who actually was a smoker in the past, hypertensive. He's been operated again once 3 years back, and he's had a recurrence. And I'll tell you exactly why the recurrence has happened. Because the point of attachment was never identified in this case. So I'm just gonna quickly sift through this part because it's pretty much the same as the last case. We're lifting the medial wall maxilla all the way backwards and start drilling. And what I want to sort of focus on here is now I'm using the 70-degree scope and elevating it off of the anterior wall of maxilla. So I sort of use a Maricel to lift the mucosa off of the bone. And why it was important in this case to do that is because the attachment is on the lateral wall. And in this case, you'll be able to identify very clearly what I mean when I say attachment. Because there is no way you can miss the point of attachment, especially in a case like this. If you identify it on the CT scan very early on, then it becomes a piece of cake for you to do it. So I use a array of instruments depending on the requirement, coblator or bipolar or drill, depending on what is required and what suits the situation. So I'm just separating that flap from the floor. Now I'm taking my vertical superior cut along the lamina pepracia to separate this tumor from the superior margin and sort of get a free edge. And same thing here, I had to use an accessory ostium as well, accessory opening as well. So I made a trephine through the anterior wall of maxilla to sort of separate this tumor from the floor of maxillary sinus, rather than remove the remove the anterior wall of maxilla. So this is exactly what I meant. You can actually see there is a bony projection here in the posterolateral wall of the maxillary sinus. And when I remove this piece of bone, you will see that the tumor is actually going into this tissue. It is not possible to sort of separate the tumor from this piece of bone. And here what I do is I actually cut the tumor at this junction now and send it for pathological examination, and then drill that residual piece of bone completely down till you see that you have nice healthy cortical bone without any evidence of osteitis or hyperostotic or lamellar type of bone or immature bone. And then and the bleeding also surprisingly will stop once you have completely cleared out this bone. I'm going to let this video run so that you kind of understand what kind of bone we are looking for to stop. I also send this bone for biopsy. So here you can start to see that now you're seeing normal healthy bone which sort of resembles the rest of the maxillary sinus. I've actually fast forwarded this video to sort of save time. I don't operate so fast. So that is the point of attachment. You can see that is the point where you get the blood supply also from. And as and when you start drilling, you will reach a point where that bleeding eventually stops. And that is the point where you stop drilling to sort of, and you're sure that you've cleared out. This is the final result after you've completely cleaned out the maxillary sinus. So this guy healed very well. I think it's been about 4 years now since I've operated on this guy. Now another case where the point of attachment was along the lamina peparissia makes it a little more challenging because this tumor was going up to the anterethmoid artery as well. I had to sort of ligate the anterethmoid artery and remove that part of the lamina peparissia. That too, it was in the posterior ethmoid. So as soon as I removed the lamina peparissia, actually the periorbita was quite poorly formed, or it was sort of deformed in this case. And when I removed the lamina peparissia, the muscle actually came into view. But that is what made it a little more challenging. So here you can see that the frontal sinus is open. I'm using a 70-degree scope, and I'm just curating that area carefully to sort of delineate the lamina peparissia, remove that mucosa there, and now I'm lifting the lamina peparissia off. So this was one patient who had dysplasia actually. When we did the biopsy, we actually found that this patient had dysplasia. So you can see that the orbital contents are now herniating into the nose. But it is important to go behind that area and sort of clear out the disease completely. So just push it with Surgicel and go ahead and finish the rest of the dissection. Now, another case where we had sphenoid sinus and lateral recess. This was a very funny case because this patient actually, the point of attachment was in the lateral recess of the sphenoid sinus, which is quite rare. I've never seen that. So straight away we have done a posterior septectomy here and sort of created a wide two nostril approach to address this tumor. And you can see most of the tumor is lying there. It is arising from the floor of the sphenoid sinus and adjoining part of the lateral recess as well. So that is the keel or the rostrum of the sphenoid sinus, which we elevate the mucosa and sort of drill it down. Once we drill it down, we have good exposure to look into the floor of the sphenoid sinus. And once we look into the floor of sphenoid sinus, we can actually separate this tumor from the floor and peel it off nicely. This is the intersphenoid septum, which I sort of take down with a through cut punch. And remove that piece of bone to sort of give me a wider, nicer exposure and to be double sure that that bone is sort of not left there and it can become a nidus for regrowth of tumor if at all there is even a small attachment there. So that is the point of attachment. That what I'm touching is actually the Vidian canal. You'll be able to see it very clearly. That is the posterior wall of the maxillary sinus. When we remove that tissue there, it will communicate with the lateral recess of sphenoid sinus. And that is me using a Merocell to sort of peel that tumor off of that area. And we want to keep that area open for visualization in the post-operative period as well. So once we drill that bone down all the way completely, then you will be able to see that is the lateral recess has been joined with that sphenoid sinus now. And that is the Vidian canal, which has been sort of excised. And that is the last bit of tumor which is attached to the mucosa is being peeled off. So that is the end result. So you can see a nice, healthy, clean cavity there. That is the Vidian canal here, what you're seeing. So another follow-up I want to show you is of the frontal sinus involvement in this patient on the right side, along with another attachment site in the medial wall of maxilla. So this was actually a double attachment. Patient had two attachments. One is along the posterior wall of frontal sinus, and one is along the medial wall of the maxillary sinus. So this is almost 3 years post-surgery. So you can see that the sinus, the infraorbital nerve is seen. That is a maxillary sinus, very beautifully visualized. And the whole of the frontal sinus. We did a draft 2B in this case, and we were able to actually have a very wide opening, which allows us to look into the sinus as well without any issues. So this patient is still in follow-up with us, and he's doing very well. We haven't had a problem. So here, this is a histopathological slide where we see that this is the mucosal lining of the inverted papilloma, which has grown into this bony crevice here. And this is a widened osteoid beams that you see, and there is acellular matrix which is penetrating into this bone. That is typical of an inverted papilloma specimen. So these are specimens from my patients, where you can again see these trabecular projections going into this bone here, and that goes again in favor of inverted papilloma. Same thing here. See these trabecular projections here, which are going into this bony cellular areas. So if you compare radiographic and histological samples of these inverted papillomas, you will see that there is an irregular surface between the tumor and bone, which actually makes it very high risk for recurrence, because there are certain crevices which are created into which this tissue grows, and it allows it to grow back if you don't remove it along with the bone. And there is some degree of inflammatory pathology in the deep margin of the bone, which makes it very thin and friable in terms of it basically immature bone. So it allows the tumor to penetrate much more easily into the bone than if you compare it with thick mature bone. And all cases had osteotic changes, especially at the site of the tumor pedicle. So this is another, the study also found that this immature bone which is created because of high blood flow through the tumor, actually it reduces the barrier of protection that bone offers to growth of such tumors. And that makes it easier for the tumor to progress into the bone. And like I said before, the mucosal tissue grows into these crevices, and that is why it's called as an inverted papilloma. And this has to be addressed, especially with a diamond drill. If you can address that during the time of surgery, then chance of recurrence will be much lower. Histopathological features which hint towards recurrence or malignant transformation are: one is the degree of bone invasion that you see. Second is if the dysplasia is of higher grade. Increased mitotic activity if there is epithelial hyperplasia into the bone and epithelial overgrowth than that of stroma, then chance of malignant transformation is very high. There are certain key markers which are also used. There was one study which actually studied two markers, that is MIB1 and cyclin D1, both of which are quite important. So the above two samples, what you're seeing here, is actually of those patients who don't have dysplasia. Whereas if you see, the markers are much higher in the lower two samples where there was evidence of dysplasia. If you take radiological determinants of malignant change, as you can see in this picture, this is actually a inverted papilloma which has become a malignancy now. So you can actually see that there is direct invasion of muscle and bone in this case, and also there is destruction of bone, which goes more in favor of malignant transformation than a benign pathology. Also, there is studies to prove that those tumors which actually invade the orbit, they have higher chance of becoming malignant tumors. I've had one such case where we had to actually accentuate the orbit as well. So this is also of importance to note, that you might be dealing with a malignancy if it is actually penetrated into the orbit. Usually these patients will, at least in my case, it was a patient who had recurrence. It was operated 2 times, and now the 3rd time it has already invaded the orbit. If you take the role of HPV or human papilloma virus, there are 2 types which are associated with, 2 categories which are associated with inverted papilloma. 6 and 11 more favor of fungiform papilloma than when compared to inverted papilloma. That means it has got an outward growth rather than an inward growth. And if you take 16 and 18, as such, 16 and 18 are called as high risk HPV or HR-HPV, and they are associated with higher chance of recurrence and malignant transformation. So if at all you want to take 2 points from this lecture, so what are the factors which are responsible for residual or recurrence, And what are the factors which contribute to malignant transformation? I've summed it up all for you. There's a very high chance if you're male. There is a marker which can be used to even follow up your patient. It is called SCCA, that is squamous cell carcinoma antigen, which is actually a marker for tumors, where if you see in these patients with inverted papilloma, if it is on the rise, then you know that the tumor is coming back. Even without doing an endoscopy, you should be able to have this suspicion that this tumor is actually probably coming back in this patient. Usually you do a baseline, and then if it's going up, then you know that it's coming back. Normally, if the patient has never been a smoker, and if you find a marker of more than 1.5, then
I've been asked to tell you that maybe if you could, shorten the talk, because
this is actually my last slide.
Sure. Okay, that's great.
So facial pain has been associated with a higher chance of malignant transformation, previous history of smoking, previous history of inverted papilloma which has been operated. If there is important paper which found that chronic inflammation along with outdoor occupation and exposure to organic solvents, higher chance of malignancy, location in the orbit and frontal sinus, presence of dysplasia and high risk HPV. So with that, I would like to thank all of you for your patient listening. Thank you so much. And I'm happy to take any questions.
Thank you, Gaurav. Excellent presentation. And I just have a couple of comments on that. And first is I'm very glad to see that you have such an extensive follow-up, because as we know that inverted papilloma can recur even as late as 7 years after the previous surgery. So it's important to have a long-term follow-up. And second thing, I was very happy to see, and we've discussed this in past also, to see another skull-based surgeon who talks about preserving the piriform aperture and not taking it out when you're doing endoscopic surgeries, especially, of course, in inverted papilloma, but also in angiofibroma where the patient is a young boy, where there's no involvement of the anterior facial skeleton. So I was very happy to see that. And we'll take the questions. And while I'm waiting for the questions to come, one more thing, one very practical aspect is that very often one of the most common mistakes is to mistake inverted papilloma for an antrochoanal polyp. And one of the ways, cues, of course, one should do an endoscopy, but one of the cues is in the nasopharyngeal area, you will see that unlike the antrochoanal polyp, this will have some sort of pseudopodia kind of appearance, which should guide you to that this may not be an antrochoanal polyp. But all in all, a wonderful presentation. Thank you so much. And let's take the questions. Are there any centers which would like to go into it?
Yes. Hyderabad, please ask a question.
Questions from this side.
No questions, sir. So now Indore, please unmute yourself and ask a question. Indore, any question? Yeah. Okay. Yeah. Chennai. Yeah. Chennai, please unmute yourself and talk, sir.
We're not able to hear the questions.
Okay, one second.
Hello.
Yes, sir. We can hear you, sir. Continue, sir.
Yeah, this is from Bangalore. Gaurav, have you done any combined approach, lateral rhinotomy with for any lesions that are already jetting out from the nasal cavity, they're hanging out?
If it's already hanging out, then I think we did one case together where the site of attachment was anterior wall of maxilla, and actually that tumor was already up to the nostril. But what I do in that case is sort of excise it enough anteriorly to sort of allow my endoscope to go in, and then coagulate that bit with the coablator and then proceed endoscopically itself. I haven't done a lateral rhinotomy for a inverted papilloma.
I've never seen you doing it.
Yeah, I usually try to do as much as possible endoscopically itself.
And what hesitates you from using a debrider, like just for a beginner?
It's not that I hesitate to use a debrider. The thing is that two things. One is if you attack the tumor directly, see, usually what happens is the blood supply comes from the posterior part. It doesn't come from the anterior part of the tumor that you can block the blood supply and then go and hit the tumor. But what happens is usually it either comes from one of the branches of the septal branch or the inferior turbinate branch, or it comes from the sphenopalatine foramen. So if you attack the tumor head on in the beginning itself, you're going to have a lot of bleeding. That is first thing. Second thing is the debrider, you just take off most of the tumor to begin with, but you've lost all that specimen. So if you want to do any kind of study on that in terms of you want to study if it has got HPV, or you want to study if there's any dysplasia or malignancy in that, if you have this whole big of tumor and the malignancy is somewhere here or somewhere here, and you attack it and you remove that off, then you're losing that vital information as to whether or not I should put this patient in a danger basket. Because that patient may not be from Bangalore, maybe be from Chennai, maybe from somewhere else who has just come to get the surgery done. And you need to be very tough with the patient to counsel them that, see, you have got dysplasia or you've got carcinoma in situ, and you need to come and see me on a regular basis. So that is something that I usually try to remove the tumor in toto as much as possible.
When it is huge enough and it starts getting attached to multiple spots, will the bone also in those spots get involved?
Yes, usually it does. So one of them will be the most important, attachment, but there will be secondary attachments as well. Like in one case I showed you, medial wall as well as posterior wall of frontal sinus. So usually both these areas you have to drill it down.
I remember one case wherein we had gone through the tooth bud.
Yes, we had done that. So we had gone all the way to the floor of maxilla as well. There was a site of attachment which we had to take it out. Yes.
Thank you, Gaurav. Good presentation.
Guwahati or Chennai?
Hello, can you hear me?
Yeah, can you hear me?
Yes.
Yes, sir.
Yeah. There are three queries, in fact, for Dr. Gaurav. Thank you for a very nice talk. How do you make up, take care of the massive loss of mucosa? That is number one. And number two is there a role of pseudofovir injections in inverted papilloma? And what is your follow-up protocol?
So let's address the first part. Usually the loss of mucosa that we see is mostly if it is involving the the maxillary sinus area. And I showed you in the follow-up that usually it recovers pretty well. We have to remember that these patients are not like our inflammatory pathology cases. We're not dealing with CRS, we're not dealing with AFRS or Samter's triad. So when we remove mucosa in tumor cases, more often than not, it recovers very well because we don't have that tissue inflammation, inherent tissue inflammation. So they don't have an issue. The only thing that we need to do is ask them to rinse their nose pretty regularly. Initially, we make them rinse about 3 times a day, and over the next few weeks, it starts reducing and we come down to once a day, and eventually we stop. And this mucosa is almost self-cleansing also. I've not had a patient who complains that I've got a lot of crusting or mucus collection in that area. Second thing is, we were talking about pseudofovir. Pseudofovir injections, there was some research which was done, but it is only to, in terms of HPV involvement in those sort of cases. But if the tumor is already there and it is already attached, giving pseudofovir injection may not really help cure the disease. That is what we have seen, because the infestation with HPV has already happened. So chances of cure from this tumor is much on the lower side. In fact, there is evidence to prove that HPV vaccination, if the child gets the vaccination before their first sexual encounter, then the chance of them developing inverted papilloma is on the lower side. So there is some evidence to prove that from a population-based study. But the evidence for pseudofovir is quite bleak. Coming to the follow-up. So I'm very strict with the follow-up for most of these patients, and a lot of time is spent into counseling them. The day you get a biopsy-proven inverted papilloma, you have to sit down and spend 45 minutes of your time to explain the seriousness of the condition because it's pre-malignant. I've had one patient who turned malignant, and the thing was he had along with this carcinoma in situ, he had another malignancy which was a Hodgkin's lymphoma as well, and he passed away because of the lymphoma. So it becomes quite important to counsel them and tell them. So initially, up to the first year, I see them at least once a month. And after that, it becomes once in 3 months. We follow them up for about 5 years. And after 5 years, I give the option to the patient. If you want, you can come in and see us once a year. And if you're too busy or you would like to do a distant follow-up, or you want to keep an eye on your own, then I just give them a sheet with all the red flag signs. I give them a sheet with red flag signs to explain that this is possible, any eye involvement or loss of smell, or if you have bleeding from the nose or nasal stuffiness. So in these cases of red flag signs, I want you to come and see me immediately. And I also make them sign a document saying that doctor had advised me for follow-up, but actually I have chosen not to.
Gaurav, there are a couple of questions. One is, what do you think about chemoprophylaxis in the form of antioxidants in high-risk cases where you think that there could be a malignant transformation later on?
So chemoprophylaxis has not, I think it's not been extensively studied, but there is no harm in putting the patient on antioxidants because it can slow down in certain cases or even reverse certain oxidative stress factors like smoking and HPV as well. But I don't think there has been a randomized control trial to prove it at this point of time, or a meta-analysis to prove it at this point of time.
Gaurav, one last question. We will not be able to take all the questions, so ask them to get in touch with you directly. And that was how to differentiate whether it's malignant or not on CT scan. I've actually explained this, but since it's very important, I'm asking that particular question again.
So on CT scan, if you find bone destruction, and again, this is not definite. So let me be very clear that the most definitive feature of malignant transformation is on histology. That is the reason why I remove the tumor in toto and I don't remove it. I mean, when I mean in toto, it could be even piecemeal. If it is very big, then you remove tumor and then you go back in and remove the rest of it. But you have to make sure that you send everything for histology. You cannot take it out with a debrider and then remove one small bit and send that one small bit for histology is not going to be sufficient. And when it comes to CT and MRI, there are only hints that it can give you. It cannot give you 100% diagnostic proof of malignant transformation. But what you should look for is if there is bone destruction as compared to bone remodeling. So in benign tumors, what happens is there is increased blood flow through the tumor. That is why you will find sclerosis, like what you find in AFRS or anything. And in that, the thing is in AFRS, for example, the sclerosis is global. That is, the inflammation is inherent in the patient's immune system. So you will find all sinuses are going to be inflamed. That is why when you open the case, it bleeds quite a lot. But here, there is one hyper focus where there is increased blood supply, and that is why only that piece of bone will actually become an immature type of bone. Basically, it becomes less dense and interwoven. So that allows the tumor to penetrate much deeper. Whereas in malignancy, there is no time for this phenomenon to happen because increased blood flow, osteoclast flowing in, removing that bone takes a lot of time. When it is malignant, it just infiltrates the bone. Short history, bone infiltration, loss of tissue plane, muscle infiltration on MRI, these are all signs that it has become a malignant tumor. If it has invaded into the orbit, invaded into skull base, chances are that it is malignant. So these are the clues that you have to look for. But whatever said and done, your biopsy is going to prove ultimately whether or not it is benign or malignant.
Also, I think occasionally on MRI, there's loss of that cerebriform appearance at the area of malignancy. And sometimes on PET scan, you may see local area of increased activity as compared to the rest of the tumor.
Yeah.
So with that, thank you so much, Gaurav. It's been a brilliant session. And I hand it over again to the organizers.
Thank you. Thank you so much, ma'am.
Thank you for the wonderful session, Dr. Gaurav. And now I would like to welcome our next speaker and introduce him, Dr. Madan Kapre. So, sir is a very senior consultant from Nagpur and Lifetime Achievement Awardees of FHNO and Lifetime Achievement Awardees Academy of Otolaryngologists of India. So was National President Foundation of Head and Neck Oncology and founding National President Thyroid Surgeon of India. National President of Voice and Laryngology Association of India, and as well as mentor for the Fellowship Program Academy of Otolaryngologists of the India since 2018, as well as for the Fellowship Program Foundation of Head and Neck Oncology of India since 2019. Welcome, sir. And we have Dr. Hetal with us for the moderation of the session. And we have ma'am here with us also in Mumbai. So ma'am is professor and head of department of GS Medical KEM Hospital and recipient of E. Merck Award for her work on CSF Otorrhea, as well as RAF Cooper Award for her work on stroboscopy. And ma'am's special interests include micro-ear surgery, endoscopic sinus surgery, microlaryngeal surgery, and cochlear implants. So before I hand over the session to the speaker, we would like to felicitate ma'am since she is here. I would request Dr. Sameer from Alchem to felicitate ma'am. Ma'am, please welcome to the dais. Thank you, ma'am. Now I'll request Dr. Madan Kapre, sir, to begin his session. Just a second.
Before Dr. Kapre begins his session, I just wanted to come in. We've already seen the book by Dr. Subir Jain. Just want to show you two publications from Dr. Madan Kapre, which are internationally renowned. They are right now available not only in India, but the United States and Europe. So one is his book. As you know that he's got a passion. He's been doing camps on thyroid surgery. So can we have the picture of the book on thyroid surgery, please? That's Dr. Kapre's book on thyroid surgery. It's absolute complete coverage of thyroid from A to Z. And as I said, it's in circulation, not only in India, Asia, but also in the Western world. And the second, I think, is on surgery for trismus in oral submucous fibrosis. And I don't think there is any other person in the whole world who has as much experience in this kind of surgery as Dr. Kapre. So we're eager to listen to Dr. Kapre on his presentation of surgery for submucous fibrosis. Dr. Kapre.
Dr. Kapre. So can you hear us?
Sir, can you hear us, sir?
Yes, I'm with you. I'm
Yeah.
just getting my slides in place, and I think I have. Can you hear me too?
Yes, sir. Yes, sir.
Okay. Well, thank you very much, Dr. Kirtane sir, and all the team who are behind organize this program, the Alchem people and all the backstage workers. I'm grateful for giving me an opportunity to share my experiences on management of trismus because of oral submucous fibrosis. Now, it completely changes the tenor of the presentation so far, and we are going into an area which is probably nobody wants to enter. We have, as we all know, there is a national bird, beautiful pictures. We have got a lovely national flower, another beautiful picture. We have got now national sports too. But now recently it's not cricket, it's hockey. But be that discussions apart, whether it's cricket or hockey, there is no dispute that we have a common national passionate pastime, which is indulging into the ills of tobacco, be that a smoking form or be that a chewing form. And there are available numerous ways of indulging yourself into it. And this leads to a very unique distinction of having a national mouth. Now, you never have thought of this, but that also brings you another unique distinction amongst the international community of being called as the capital of oral cancers and, of course, the submucous fibrosis. And this disease is very, very unique. And the trismus that leads because of the oral submucous fibrosis is some animal or some kind of a beast I had never seen, although I was born in the tobacco land. You see, we are in the Madhya Pradesh bordering Maharashtra, and we inherit all the now lovely culinary habits, and of course, the chewing tobacco habits from the central India provinces, old time called the Berar district. But I was very naive. Maybe my training was entirely in United Kingdom, so I had never seen this beast called oral submucous fibrosis. So when I come back, I was like Arjuna, not knowing, having known everything how to fight, but losing his heart at the last minute, because you did not know anybody and there was nothing to offer in the literature from the Western world. Now let's analyze this bull called OSMF. Now, when this bull hits you, even the brave hearts run helter-skelter, and there is no way you can run away. You see the facial-maxillary, the dental, the ENT, the oral cancers, everybody just doesn't want to know about this condition. But the pride of my FRCS was not letting me accept my defeat. And there begins the journey. And this particular talk is about the challenges that I faced in last 2 or 3 decades, maybe more, while dealing with this condition, not just on its own, but also in association with oral cancers. Now, the journey begins with somebody who just can't open his mouth, and the journey rightfully should end where you have got 4-finger mouth opening at the end of the day. Now, how do you achieve that? And that's what exactly we are going to see over the next 25-30 minutes. What are the challenges on the way? The very first challenge is stop the habit. Now, is that so simple? Stopping the habit is easy said than done, because if you see, I'll show you 3 pictures of stopping the habit. This particular gentleman on the left is actually a doctor who continued to chew tobacco, and oddly enough, a surgeon, young surgeon, and ended up getting the oral submucous fibrosis turned into oral cancer. Look at closely at the picture on the left. You can see a gentleman with a tracheostomy. And do you know why he had a tracheostomy? Because he had a CA larynx. But does it stop him indulging in tobacco? No. He goes on to smoking, change into chewing tobacco, and ends up with oral cancer and succumbs to it. So habits don't leave, the people leave. Look at this young lady. She is a doctor again, and she is from the Gadchiroli district, where we used to have some camps for the tribals. And despite of several things, she never ever stopped and ultimately again succumbed. So stopping habit was not the option. Now, understanding trismus of OSMF is vital. Now, look at this. This is a pathophysiology. We all know that how it begins. But how does this interest a surgeon? Now, from surgical point of view, this is what we want to know. The pathologist is interested in, is it pre-malignant? And you can discuss about this till cows come home. Oral medicine people, can you reverse it? You can pump in vitamin A, all kinds of alpha lipoic, I mean, you name it. There are so many things in the market. You can pump in till they come out of the ear, and still we will not know whether can it be reversed. And as a surgeon, what we are interested in, the trismus. Can we do something about the trismus? So we get them at the last bit. We don't get at the stage of vesiculation. We don't get them at the stage of hyalinization. But what we get as surgeons is when they are actually unable to open their mouth. But is it just that? It's not. You see, it affects several parts, and that's, if you fail to understand, you are not going to get a good result. The muscles not only become rigid and fibrous, they actually atrophy. So your masseter is not only hard, but it's also weak. The unerupted molars, you only find them as we go along the surgery, and you cannot get at them even in the beginning. The cheek soft tissue is reduced, the cheek fat is gone, the tongue bulk is reduced, and the condyle becomes flatter. So if you stretch your lung too much, which I will tell you later on while I'm discussing the surgery, that the anterior rim of glenoid fossa is very, very shallow and very easy to get a dislocated TM joint at the end of the surgery. Now look at this man. I'm trying to show you to put all these things in right perspective. Good result, would you say? He's opening his mouth nicely, but is he happy? No, he's not, because the tongue bulk was not addressed and he could not initiate the first bit of swallow. Rise and push the bolus on the palate and back to the fat. So you have to pay attention to every little detail of your patient. Now, before we get into surgery of any kind, no matter how stiff the submucous fibrosis is, there is never pain. The pain indicates malignant infiltration. There is never ever halitosis, because halitosis means osteitis, means necrosis, equally means again malignancy. The sudden
Hello, Madan sir, Kapre sir, can you hear me? Hello, sir. Sir, can you hear me? Hello, sir. Sir, can you hear me? Just unmute, sir.
Yeah.
Yeah, hi, sir. Yeah, continue, sir. We can hear you, sir.
Yeah, okay.
Just share your presentation, sir.
Yeah, okay. Is it on right now? Can
Yes,
you hear
sir.
me?
Yes, sir. Just
Good.
you can stop your video, sir, and share your presentation. Might be you
Okay.
have a bandwidth issue.
No, we don't have a video, but let's see. Mhm. Yeah. Now, the next question would come that who should be actually doing this?
Sir, 1 second, you are disconnected, sir. Yes. Yeah. Sir, can you hear us?
Hello?
Yes, sir. Yes, sir. We can hear you, sir.
Yeah, okay. You see the weather here is
Sir, just can you share your screen, sir? We can't see anything, sir.
connection, sir.
Sir.
Yeah.
Yes, sir. Sir, can you hear us, sir?
Yes, I can hear you now.
Yes, sir.
But can you hear me?
Yes, I can hear you, sir. Just share your screen, sir.
Yeah, screen is being shared. Yeah.
Sir.
Is that all right now?
No, sir. We can't see anything, sir. So there's a one green button is there, share screen.
Yeah. Okay.
We can't see anything, sir, till now. Sir, can you hear us, sir? He's connecting with the hotspot. Okay, fine, sir. Fine, sir. Meanwhile, sir, if anybody have any question, they can take.
Ma'am,
Take
there
me
is
to
questions from the audience so that we don't.
Ask the organizers to take control of the screen.
In the audience, please let me know.
No, it's not. It's not our crowd. There is network issue at Dr. Madan Kapre's.
In the meanwhile, if anybody has question, to let you know a little bit of history of it, Professor Schwartz, when he visited Kenya, he had found this condition, which was incidentally found in Indian patients only. And that time he gave the name to this condition, which was very much similar to the submucous fibrosis. And he said that it is atrophia, or means he meant to say that there is an atrophy of submucous region. And then later on, a year later, Dr. Joshi, who's, as already Dr. Kirtane told you that he was ex-head of the department, described the terminology for as a submucous fibrosis. When Professor Schwartz visited Kenya, he saw this condition in 5 Indian women only who were consuming betel nut. And that time he said it is atrophia idiopathica, which was involving mucosae oris. So he gave this terminology, and which later on was labeled as submucous fibrosis. Now, as Dr. Kapre already has mentioned, that these are the various issues and challenges in managing this submucous fibrosis. I think he has got.
Yeah, thank you, Ethel, for yes, thank you very much. The next issue is actually of team building. By that I mean that it is not a one-man show. It's not a one-man surgery also. It involves a lot of people, and therefore you have to develop your own team. And these are the sort of people you want to be on board. You want to have an interested dental surgeon. You want to have a facial-maxillary surgeon who's also interested. You also want to have an oral pathologist, but if I may say so, equally important is the anesthesiologist, because they play a very important role in the beginning of the surgery, and may I say even later, because they also are helping you with the pain management in the post-operative period. The physiotherapist, of course, because the make and break point at the end of the day following surgery will be naturally the oral hygienist and the physiotherapist. Psychiatrist, yeah, of course, because a lot of these patients do have a genuine psychiatric issues, and probably chewing habit of tobacco or smoking excessively or alcohol may be an outward expression of some underlying psychiatric problem which we might actually miss. So everyone is important but you. And the reason I say but you is because it's very easy for a surgeon to gloat in the glory of a good surgery and forgetting everybody else. Now, training of a surgeon, this is a very, very important issue. How do you get trained into this particular surgery? And that's again is not simple, because there is no literature available, there are no books available, and we are forced into publishing our first book, which was Management of Oral Submucous Fibrosis Trismus. Now, I was surprised to see that the publisher actually hiked the price so much. I was myself quite amazed at the price, and the thing what they said, sir, there is just no other book, so we can price it very happily. Now, how did we started our training? We started thinking, what can we do? We had all the knowledge, even we looked up to the heavens with a binocular, maybe he will give us some idea. Every time we had some idea how to deal with this trismus, we used it and the bulb fused because it just didn't work. We failed it in about few days, a few weeks, or sometimes in few months' time. Then I went along asking people. And the more I asked people, the more I got discouraged. And one of the surgeons, which I'm gratefully going to mention later on, actually said to me, Madan, you are a very well-trained ENT surgeon. Why don't you go and do otology? Why don't you go and do rhinology? Just leave it up. It's a bad job. And I got more and more disillusioned. And therefore I said, nothing is going to work. You have to work it yourself. And therefore I said, do it yourself. Next was selecting a patient. It is very, very crucial that you don't get very, very choosy. Not that everybody who comes with you for a Christmas is somebody you are going to operate. The strict abstinence for more than 3 months is something which is a prerequisite. Why do I say 3 months? It does two things. It ensures that your patient is going to cooperate, is willing to give up his habit on chewing, and maybe he's motivated enough, because patient's motivation and the family's motivation is extremely, extremely important. You should have a good psychiatric profile on your patient to ensure that he doesn't land up into any kind of depression post-operatively, should he have to have a lot of pain and a lot of exercises. Earlier treatments, you should know always whether he had steroids. Many times you'll see they had some sort of a surgery done. And the worst kind of a surgery that you can have done before will be band division. That means somebody has gone in either with a cautery or with a laser or whatever device, and they have just cut the bands, opened it up, only to find that they scar even worse and your job is even more difficult. Of course, you must take into account the socio-economic background of your patient, as we all do for all our surgeries. Now, the thing about the surgery, the key thing on surgery is keeping the wedge open. Because you know from the area that if you don't keep the wedge open, like this wood failure is doing or the tree failure is doing, it cuts into a wedge and the whole weight of tree will break the wood. Similarly, if you leave a raw area at the end of the day, you leave granulations there, it will fibrose, cause scarring, and trismus reoccurs with vengeance, and you only have got one chance. Now, keeping that wedge which you have created open requires teamwork, as I said, and in this team, a lot of people will come in and a lot of thinking will go in. Or else you will put your foot into the mouth, as this famous picture of somebody we know very well. What are the available options for keeping this wedge open? You can slap bang there a split skin graft. You can put in there a full thickness graft. You can put tongue flaps, palatal flaps, fat flaps, nasolabial flaps. We will visit them one by one and then come to see what I settle down at the end of the day. The selection of surgical procedure is a crucial one. And the things to do here is to see from your own mistakes and keep analyzing. I will show you that among the large number of cases we have done, the lateral based tongue flaps were the initial things we did, and you can see we gave up within 32 cases. Everything was good. Good vascularity, lying just next to where you created a gap, good posterior cover, but the big advantage or disadvantage was it has poor anterior reach. It gets pulled back because tongue is a very mobile tissue, very strong, and every time the mouth is opened and the man wants to speak, the flap gets pulled back and causes severe dysarthria. And it does require a secondary division on many occasions. So after initial 32 patients, we gave up. Bad job. The nasolabial flap. Now, right under sort of a less than 50 kilometers from where I work, there is another advantage, locally available, rests entirely in the buccal sulcus. But the big problem is it causes an external facial scar. And it also has a tendency now pulling anteriorly or pulling back. It has a poor posterior reach where exactly you want it to reach. And the reason why I said we only recommend where the indications are right. But otherwise, you can see after 18 cases, I gave up. And gave up because I saw this gentleman. Look at him. He's a salesman, hardly can open his mouth with two great big scars on his face. Let other people make mistake and you learn from them. Fat flap. A lot of people do this thing. You can just pull down a little bit of fat from the cheek, spread it on the area which you have created raw, and just tuck in some sutures. Very, very easy. This was actually told to me by one of my plastic surgical reconstructive friend from Cochin. And he said, Madan, why do you sweat so much? Just do this much. It's a very poor performer. About few days later, the patient will chew and throw away the flap into your hand. Now, palatal flap. The palatal flap is something which is exceedingly well and again advantage possible, but the big disadvantage is it creates a shell. I'll show you that. This kind of a result you can expect to get even after 4 years. Wonderful flap. I do it very frequently, and that flap is something which is practically replacing the flap which is going by our name of the institute, the mandibular mucoperiosteal flap. Now, I learned it at the Cancer Institute where I was working, that if you can have a lot of medialized mandibular mucoperiosteum, and that can be used to reconstruct the cheek, why can't I use the same flap to cover the defect which I will create at the end of the trismus surgery? With that logic, we did publish the first flap, and it looks something like this, that you raise the medial aspect of the mandibular mucoperiosteum, raise it and take it into the cheek and bring it as much anterior you want and cover up the entire defect with a very nice, soft, supple mucosa, which is the medial aspect of the mandibular mucoperiosteum. But again, it had its own problem. Although everything was very good, the big disadvantage was it doesn't come anterior enough. Now, so we again modified and we published another technique which was called as a mandibular mucoperiosteal flap revisited. And how did we revisit it? That we did not actually insist on bringing it right forward, but we only used it to cover the back bit and modified our incisions, which I will show you in a short while. And that also works very, very well. Now, the significant change in my technique occurred in this famous story of the gentleman which I mentioned, who was telling me that, why do you want to do this surgery? Please don't do it. Give it up. And the same gentleman, once I met very accidentally, and I saw him doing something which changed the entire surgical perspective in future years, and that was coronoid excision. I mentioned few steps of this because this is not mentioned in any books, and people will find it difficult to understand how do we go about doing coronoid excision. You put a wire on side incision in the cheek, identify the anterior border of the coronoid process, and then do a medial and lateral release. Medially, the pterygoids, and laterally, the masseter. Go up to the apex to release the temporalis and then excise. Let's see how. Now, this is the beginning of the surgery. I'm using laser to cut into the anterior bands. This is how it actually starts developing, that there are 3 areas of bands, one circumoral, one coronoid, and the last is the anterior posterior or the anterior pillar. Now, you cut on both sides equally at the same time, because otherwise you will get tears. And then you do the posterior cut, something like this, to extend the cut as much back up to the anterior pillar of the tonsil, and then come back on the medial aspect of the mandible. This is how it looks when you finished. And you can just see a little bit of fat peeping in. You try and avoid not getting too much of it into your vision, otherwise it keeps pouring down there and spoils your surgery. Now, this is a new technique. And this is what I meant, that when you grow, you just take one vertical incision and just cut it like a cross and don't make a Y. But this again is something which we developed later on. And now this is a standard technique that go on the last bit on the anterior border of the coronoid and just keep on working there to expose the entire coronoid process. I'm showing this deliberately because you can see that black mark. That black mark are the laser marks on the anterior border of the coronoid. It is important that you get these borders right, because you go either on one side or the other a little bit, you sway by a millimeter and you will get bleeding, because the medially it is the medial pterygoid, which is very vascular, and laterally, which is the lateral pterygoid, which is very tough and also doesn't spare you from bleeding. So stay there, and then this is how the entire coronoid process get exposed. And once this is exposed, bingo, you can cut it the way you want it, and you release up to the tip, and then you go either with your standard drill, or you can go with even hammer and chisel, and you get a piece of triangular coronoid process at the end and release. You try to retrieve it. Don't leave it there, because I have seen many people at this point get tired, give up, and then just say hammer, 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 and the coronoid flies away into the infratemporal fossa because of the pull of the temporalis muscle. Now, how would that bother? That bother will be because if you do that, then probably what is going to happen is that it is lying there, creating a foreign body reaction and more scarring and fibrosis and pain in the post-operative period. Now, this is how you can achieve a terrific, satisfying mouth opening when you finished it doing on both sides. Now, I put this picture deliberately to show that something which I do not do anymore, which I used to do in the past. For example, you can see the Ryle's tube there. I do not put any more Ryle's tube. The reason being, the more the patient is motivated to swallow, the better it is, because it improves the oral hygiene. Now, why did we move on from there into the platysma myocutaneous flap? The only reason was we required larger flaps. And then this particular flap was not good enough, because not big enough. And therefore, we decided to go up in the neck. Now, the incision lies very low in the neck, so you don't see the incision at all at the end of the day. And I will show you them with some pictures. This is where the incisions lies. We are borrowing the skin along with the platysma attached just above the clavicle on either side. We develop the flap like so. It's a large, flat platysma muscle with a skin on the top of it, and then feed this flap into the oral cavity alongside the lower border of the mandible, which comes and sits very happily inside the oral cavity once you deliver it there, and it's something like this. You can see how beautifully you can take any size. Now, do we have problems with this flap? Of course, we have problems with this flap, and the problems with this flap is that you can energetically, or you can in a great enthusiasm, take a bigger flap than you require. And then you end up getting this flap chewed at the end of the day. So you should just have a right size of the flap, and it looks beautiful. Now, don't push your luck. At this point, you are tempted to push the luck, because remember what I said, that you can dislocate the temporomandibular joint, and that can be a disaster. Because if you dislocate, it has a tendency to redislocate, and your post-operative physiotherapy is in a jeopardy. This is what the platysma looks like at the end of the day. Now, what do you learn from this? Because every time we are learning, and the thing we learn that we can probably dispense off with the skin, and we can probably just use the platysma with the fascial covering on it, because then it may mucosalize faster, and therefore we can get better results. So that's the next change, that we don't use skin, but you only use the platysma with the fascia on the top of it. It actually gets better. You can see from two pictures. The picture on the left, it still has a tracheostomy, which we had done for airway in the beginning. Now the tracheostomy is gone, but the man is actually opening his mouth much, much better than what he did. The two factors, probably one is no pain, and two probably is that the muscle slightly atrophies and gives rise to a lesser bulk. Now, what's most important in managing trismus is be honest and a desire to accept failure and move forward and not getting depressed or stopped. And I give you one example how we have to change. In the year 2000, I acquired laser, and I thought, bingo, it was like George Washington with his sickle knife that go everywhere hacking all the trees. And we thought we could do wonderful, because the people also told us it doesn't cause any scarring. We believed it, and we did it. And we did this surgery. We call that as an island surgery. That means we create an island of mucosa between the upper and the lower and make it two parallel cuts. Very easy, very easily doable, opens up the mouth quite nicely, but failed very badly. And therefore, we stopped doing it. Maybe even after a few months' time, we stopped doing it, because the mistake become experience, and the knowledge, if you learn from them. And you learn from your mistakes all the time. The more you operate, the more you make mistakes, and the more you learn. And here is Voltaire coming your way. That always listen to others who might be doing something different than what you are doing, because then you might get an opportunity to examine and sort of critically analyze your work with their work, and in the process, you only improve. The anesthetic difficulties. Just because this particular slide is not shown because my wife is an anesthetist, she's a wonderful lady and anesthetist, but they have a problem of intubation and getting airway secured. Now, first thing my wife learned was blind nasal intubation. This was an era where the endoscopes still haven't come. And this technique can allow you to intubate because you keep on listening to the sounds and put your tube in place. It's a wide awake patient breathing and the tube is guided in. But then came the era of bronchoscopic intubation, which was quite easy, and not so blind intubation where you got a tip camera at the end of your laryngoscope and you can glide in your tube, not so blindly, but with little bit of help from this camera. If all else fails, tracheostomy is something you should not shy away from. It's only for a day. Be considerate about the laser safety of your anesthetic tubes if you are going to use a laser. And be also aware that post-operatively, you should have a nice, secure airway of your patient. And the last is maintaining the operating results. No matter how wonderfully you operated, the whole make and break of your surgery lies upon the post-operative thing. And this is something which is very easily doable. It is a door stopper. A door stopper get converted into a Christmas stopper, and the cost is only 25 rupees because it's only a piece of wood. There's nothing to it. But you do that and you make sure that the patient has got, because they can buy fancy things. You can buy things up to 15,000, maybe 25,000, all kinds of different gadgets which are available in the market for keeping the mouth open. This is the simplest of the thing. How do you do it? It's very simple. You do this on the day 2 and you ensure that he keeps it open. How? Like that. You keep that wedge in his mouth and you show it to the entire family that this is what I have done. And I want you people to put your patients continuously on the alert and on the exercise that he maintains that wedge at the end of the day. This is great motivation. It takes a lot of time, a lot of pain management, a lot of persuasion, but it works because it is worth rewarding when your patient still opens the mouth as big as he's opening after 3 months or even better after 6 months. It is very rewarding to keep pushing it. Now, the last slide is just in case anybody got interested in doing this kind of surgery. The boats are built to sail the rough seas and not look smart and beautiful and handsome with our great coats and your OT apparels, but we should still look good with our good results at the end of the surgery. So if you are a good surgeon worth your salt, take on this challenge and start operating on the trismus of oral submucous fibrosis. Good luck and thank you again very, very much for bearing with me through this internet sort of off and on going. This is because I'm middle of the Pench jungle, hoping that I might see a tiger. And I was going to actually tell you that if you see some roaring at the back, probably warn me so that I can quickly turn back and stop presentation and run away from the place because I'm bang in the middle of the nowhere.
Hello. I don't see many questions here. I think everybody's hypoglycemic. Any of the center, if they have question, please.
Yeah, there is one from Ranchi.
Yeah.
Unmute Ranchi.
Already unmuted, sir. Rachi, please ask question, if anything. Guwahati, now you unmute.
Hello, can you hear me?
Yes.
There's a query for Maran Kapre sir and a comment as well. The query is regarding, teenagers with submucous fibrosis. How frequently have you dealt with them surgically and what is the outcome in teenagers below 18 years?
Yeah, the main issue with teenager is the peer pressure. You see, oral submucous fibrosis doesn't occur in everybody who indulges into chewing habits. So their friends are actually our enemies because they will keep on telling, "Arey, what is he telling? There's nothing to it. See, I'm eating, nothing happening to me." So the first is to ensure that that teenager has got all his friends along with him at a sort of counseling session, that you not just talk to him, you talk to the family, you talk to the friends. And if he's willing to give it habit, at least for 3 months, sometimes you can actually see him improving. Because if the fibrosis has not really settled in that badly, he actually does improve, in which case you may not have to operate. So you keep on pushing the date forward and forward till you are convinced that this is not going to anymore improve, and you are convinced that the patient is going to cooperate, there is no harm. I mean, you could see that boy, last but one picture I showed, he was a second year engineering student. So there is no problem. You can operate provided they are motivated enough.
Sir, the comment is, you are the sort of undisputed authority in India today on dealing with submucous fibrosis. We have heard you so many times, and every time it's been a revelation. While we actually counsel patients with oral sub.
Hello, just unmute, sir. Unmute and talk, sir. We can't hear you. Guwahati, we can't hear anything, sir. So.
They also can't hear it.
Hello.
Okay. Yeah, now it's fine, sir. Now it's fine.
Yeah. The comment is actually, Dr. Kapre sir, we have heard you so many times giving various talks on submucous fibrosis management, and you are the undisputed authority in this regard, because every time we have heard you, you have something new to offer. When we counsel patients with oral submucous fibrosis, especially in the illiterate or the semi-literate people, we have to give them this big term. What is the disease? Oral submucous fibrosis. This is an Indian disease. Can we not come up with an Indian name?
Gutka, I don't know. We'll think about.
Hello, Kapre sir.
Yeah.
Is there still a role of triamcinolone injections? Kenacort injections, which we used to follow long time?
Yeah.
And what is the schedule like? How do you give it, and whether it still has a role?
Yeah, to be very honest, there is no role whatsoever. It doesn't do anything. The trismus once set in and the fibrosis once set in cannot be taken away by any topical injections of any kind. I tell you a little funny story about the time when people even use Placentrix. Has somebody used Placentrix injections? It's like a fibrosis dissolving kind of because of the enzyme destruction of the fibers, and they come back with vengeance. So I will not recommend. Having said that, there is one place which is definitely a role for injectable steroids in this cavity, in the wound after the surgery, because that will prevent some amount of granulations will be reduced, the scarring will be reduced, and you will get a nice pain-free. I mixed that up with bupivacaine, which is a local anesthetic agent, and a combination of bupivacaine and long-acting steroid once in 15 days is a pain management protocol in our center in a post-operative scenario. But there is no role or no thing for pre-operative or trying to improve the trismus.
So how many injections do you give post-operatively, and how do you space them?
Sorry?
How many injections do you give post-operatively, and how do you space them?
Yeah, as I see, there are two ways of injecting. Whether you can inject it from outside, go below the zygoma, which is much more safer and much more accurate. But if you're not trained in giving that injection, you can even go intraorally. You space it for 2 weeks and you bring them in and give the injection, wait for 15 minutes for the bupivacaine to act, and then reopen their mouth to the level which you had gone before and leave it there for 15 minutes. And that will show two things. Number one, the patient's confidence level goes up, that if his pain is sort of encouraged to carry on with the physiotherapy. Once every 15 days until the wound completely settles down, probably for 3 to 4 months.
Thank you, sir.
Sir, I have a question.
Sir, we have a question from Mumbai, sir.
Sir, are you using Hyalase?
No, as I said in the beginning, that all these so-called proteolytic or enzyme preparation are not used anymore. It was used in the past As I said, people use Placentrex, which was a placenta extract, but no, don't use it. Don't use it. Don't recommend it either.
And sir, when you talked about coronarectomy, are you combining that with flaps, or you are doing that as a sole procedure, or what is it?
No.
That is a question from the audience.
Good question. It is always. See, the one thing I learned from others' mistake was a gentleman who taught me to do coronary excision. The fellow who gave me this idea, I will not name him because we all know him. The same gentleman, I bettered the result by providing a mucosal covering over the area I created as a raw area having excised the coronoid. Because if you leave it open, if you leave it unexplored, then sure enough, that will granulate and that will cause more scarring. So we want to cover that defect. And that's why these three flaps, mandibular mucoperiosteal flap, palatal flap, or the platysma myofascial flap now, which used to be myocutaneous in the past. So these are the
Sir, I'm from Mumbai. Hello.
Three defect I created and how much anterior defect is. If the defect is mostly posterior, the mandibular flap and the palatal flaps are good enough. But if the defect is coming very anteriorly, then probably the platysma myofascial flap is better.
Madan, just one suggestion. You continue talking, but switch your video camera off so that the audio becomes clear. You can switch your video camera off and only talk so we can hear you.
Yeah.
Yeah.
So, sir, I'm from Mumbai. I want to make 2 points. Actually, what I feel when we do our SMF cases, we always do a CT scan before taking the patient because, the patient may have a TM joint problem also. So how do you address that? Have you come across with a patient with have a TM joint patient also? Because we have made this protocol, all this patient, but this can have a articular dislocation, articular fixation also and ankylosing also. One thing. And second thing is, as you said, that the coronoid can go into infratemporal fossa.
The first part is the...
Yeah.
No, we lost you.
Yeah.
Sir, can you hear us?
Take the question in 2 parts. The first part is ankylosis, either bony or otherwise. One question. And the second question is, how do you handle dislocation should it happen? Am I right?
No, sir. How do you rule out?
Yes, correct. Now, there are 2 ways of ruling out. Either you could go the scan way, which you just mentioned yourself, or if you want to do it, you can do it by way of just making sure that he at least has some movement there. Put your finger there and palpate the TM joint moving. This is one way. The second is when you are actually operating on these patients and you find out that you are just not able to budge the joint, is to physically examine the joint and deal with it. Only on 2 occasions, I had to take help from my plastic surgical colleague and do even a sort of open up the joint and take away the head of the mandible. That's very rare. It doesn't happen. As long as you know that they are moving by putting your finger in the front, CT scan is not a bad idea at all. But what is more dangerous or more difficult to manage is when you reopen the joint. And I said, if you remember one of my slides, I said, don't push your luck too much. If you open it too much and the glenoid fossa is shallow, the joint dislocates. Now, if that happens, then you are in trouble. Because with that happening, you cannot push your physiotherapy hard in the post-operative phase. Because if you put it very hard, it keeps on dislocating. And it has occurred to me in a lady which was super VIP, and then he had a barrel bandage, and then we had a real tough time and not knowing when to push in with the physiotherapy because she kept on dislocating. That's a genuine issue. But the first question is even more important of getting it right, that the patient is not suffering with TM joint ankylosis, either fibrous or osseous, either of the 2.
So second thing is, sir, the small suggestion is like, to prevent how to that your coronoid should not go into infratemporal fossa. So what we do is we put a IMF screw there and we put a wire there and then start doing a drilling. Okay. And then we remove it so that, it will not go into your infratemporal fossa. So this is what we do. So just
good idea. We'll try to do that. But my own idea is to ensure that the triangular apex of the coronoid is exposed so that we ensure that there is no muscle. You see, posterior is a lot of fibers attached. unless, and there's a special, the Johnson & Johnson people has produced a very nice right angled cautery. We can put it at the apex and run it down on both sides, in front and the side. And if you're friendly with them, they can give it to you one, a sort of a pointed cautery with an angle, so that you can run it on the back end of the coronoid to ensure that all the fibers are released and the muscle are cut, so that the temporalis doesn't pull off the apex of the coronoid in the infratemporal fossa. Very, very important thing to not let happen.
Dr. Kapre? Thank you very much. Thank you very much for giving an insight into such a difficult topic and sharing your experience with all of us. Thank you. Thank you on behalf of the audience from all the centers. Thank you very much, sir. I think he's cut off again.
Thank you.
Very good afternoon to everyone. On behalf of ELCAM, we would like to thank all the speakers and moderator, guests for enriching contribution in this scientific meet of 11th ENT Conclave. This comes from the core of every ELCAMite. Special thanks to all the delegates who have been here physically despite all the challenges of this time, and also who have been connected virtually with everyone in throughout this scientific session. And the deepest gratitude and sincere thanks to Dr. Milan V. Kirtane for guiding us and navigating us towards the successful completion of this 11th ENT Conclave. Thank you, sir. On this platform, I would also like to highlight the dedicated effort of Team Aura Magna, which is a dedicated clavum team committed to take clavum care, extend clavum care, and improve the accessibility of clavum, considering the emerging need of clavum in the field of otolaryngology. We continue to enjoy the strong association with this specialty, which is very, very important for us, and each and every Aura Magna team member is putting every effort to meet, to understand the need, and to ensure that the clavum is available and to every corner of India. We are almost 1,000 people who are working in and out only for the accessibility of clavum all over India. Thank you. And right now, I will welcome our Associate Vice President, Mr. Mandar Joshi, to come on stage for the felicitations. May I request Sir to once again have this gracious presence on the stage, and we would like to once again thank you with a token of gratitude. And yeah. So, this is the Silver Jubilee year of clavum, and that's why we thought of some kind of silver felicitation with this kind of thing, a silver plated felicitation kind of thing, right? Then we have Dr. Hetal Marfatia Patel. Doctor, right now I'm very smooth with your name. I'm sorry, in the morning I was a bit fumbled bit. Thank you, Doctor. Thanks for all the contribution and coming here. Thank you. Then Dr. Renuka Brado. Thank you, ma'am. I hope you were comfortable while moderating the session from there. Thank you. Thanks a lot. Dr. Nupur is not here, so we will be making it, we will be definitely going to her place. Request all the local, wherever the program is taking place, the felicitations to continue. And thank you. Let's proceed for the cocktail and lunch. Invitation from the core of the heart. Thank you. Thanks a lot.